Good morning, everybody. It's a brave thing to be here after the yesterday's party. So we will start a little bit late with the symposium concerning aspect of stress. And we will start with Evstratia Maria Georgopoulou, who will talk about live events and psychosomatic health.
Okay, so good morning, everyone. Thank you for being here. So we will talk about life events and psychosomatic health. First of all, we will say some things about the story of stress research and psychosomatic medicine. Then we will go on to examine the relationship between stress and life events. And then we will outline some factors affecting the perception of life events from individual people. And then we will see how life events are associated with disease, and especially with cardiovascular disease, asthma, autoimmunity, psychopathology, and infections. Then we will see how the body and mainly the brain responds on stress, and some research limitations and perspectives on research on the field. So, to begin with, the story of stress research begins, let's say, officially by Hans Selye, who coined the term stress in the early 90s. And about at the same time, Walter Cannon researched about the physiology of emotion and the autonomic nervous system, and his theory was that distressing emotions can do physiological dysfunctioning. Then Adolf Meyer introduced the life chart in which he asked his patients about life events that had happened, and the biopsychological model in which life events and other factors integrate to form the total personality or psychopathology of a person. An historical event that promoted the psychosomatic medicine was the First World War, because soldiers and people who experienced it tend to have more somatic symptoms that were not explained by other things. So in 1939, the Journal of Psychosomatic Medicine came out, and in 1967, Thomas Holmes and Richard Reich made a list of common stressors, and they believed that this list was better than an unstructured history. So this was the schedule of recent events. Here we can see the life chart from Adolf Meyer. So he started by making a point on the birth of the person, and then he put on this chart the duration and the nature of some events that patients believed that were important to them. So, how stress, life events, and disease correlate? The term stress is somewhat of an umbrella term that describes situations that trigger common biological changes, and it is used in an inconsistently way across disciplines. And also, how people perceive stress varies across individuals. So there was a last paper that came out in 2006 that proposed a stage model of stress and disease. And according to this paper, there are 3 perspectives of examining this relationship. And this is integrating the epidemiological approach, the psychological approach, and the biological approach. So according to this author, stress can be viewed broadly as a set of constructs representing stages in a process by which environmental demands that tax or exceed the adaptive capacity of an organism occasion psychological, behavioral, and biological responses that may place persons at risk of disease. So how do we measure stress? There are two ways. First, the self-administered questionnaires, and then the interviews. So, for example, for questionnaires, there is the Holmes-Rahe schedule of recent events, which consists of 40 items and examine recent events that happened in 1 year ago. And then there is the first modification of this questionnaire, which is the most, to my point of view while leading the literature, the most widely used. It is the social readjustment rating scale. And then there are several modifications of this, or fitted to the adolescent population. And as about interviews, the most used interviews, structured interview, is the interview of recent life events by Peikel. So this is what it looks, the social readjustment rating scale by Holmes and Manuk. So this scale lists some life events that are commonly considered to be major, and each life event has some points associated with it, and then you add up all the points, and if the score is above 30, then you have an increased risk, an increased odds ratio about 80% to developing a disease in the next 2 years. Of course, this questionnaire does not exactly provide an insight into how these things are perceived by people themselves. For example, I may find very challenging the fact that I might get unemployed, but somebody else might not, because he may have, for example, other alternatives of living. So there are some factors affecting the perception of life events, and to begin with, the first one is the coping behavior, which is the degree of potential threat posed by events and the availability of resources needed to cope with them. So if somebody feels that there is an increased threat and he has low resources, then he's less likely to express an adequate coping behavior, and this increases his stress, and this results into more outstanding health effects. Second is the emotional responsiveness or emotional experience, which is the ability to detect and identify strong emotions as manifest feeling when a person encounters positive and negative major life events. Which means if you have been through something like this or similar things in the future, in the past, then then the next thing that happens to you, you can cope with it better, so it affects you less. And there is also anti-emotionality, a term which I found in the first article that is listed as literature there, which is the extreme tendency to rationalize one's interpersonal situation accompanied by conflicts or frustrations. We tend to try to realize things in order to better cope with them, but if we do too much, then we may have an increased possibility of developing disease. And of course, the perception of life event is affected by the emotional support, which is the level of the person to seek help on a range of issues from parents, siblings, and friends. And having emotional support helps them cope with things and lowers disease susceptibility. Then there is the factor of age, which is that it's generally shown that life events that happen earlier in life affect physical pathology in adulthood in a different way, and mostly in a more intense way. So here we can see two diagrams. On the diagram on the left, these are from a case control study. So they took depressed patients and non-depressed healthy controls, and they measured the life events that were experienced by them. And onto the left, you can see that the white row is which accounts for the younger people. The life events that were experienced from younger people is more high in patients than healthy controls. This is not happening for older people. But what is common in older and younger people is their negative perspective that we see in the right scale of the life events that had happened to them. And also there is the factor of duration. So generally acute life events may have direct and strong effect on a person, and even a single event may be proven harmful in disease-prone individuals. On the other hand, more chronic life events may have a cumulative effect resulting into disease later in life. And of course, gender, that we will talk about later on, may affect the coping behaviors of a person. There was also this very interesting theory, which also is a meta-analysis on the inner strength in women with chronic illness. And it seemed like if women were nurtured and nurtured the facets of inner strength, it is more likely that they will experience well-being and healing. So these women that had the inner strength, which is measured through a questionnaire of inner strength, had a better quality of life with their chronic illness. Also, physical activity may be a factor affecting the perception of life events, and it is mostly associated with medium-level major life events, not that it helps people coping with them, not with high major life event load. And of course, it is the underlying chronic illness, which is that if a person has an underlying chronic illness, then they might more often report symptoms that they expect to see on themselves. So the life events and how they perceive them may be very high, but the truth is that they are not, because it's just that he perceives them, he reports things that he believes that will happen to them. And also, if there is a psychopathology substrate, such as neuroticism or depression, may affect the way people see life events. Then there is this term, the allostatic load, which is a multi-system indicator of physiological dysregulation. So what is the allostatic load? When a person's adaptive mechanism is on for a very long time, then his biological systems that are involved into it have a wear and tear effect, which in turn make him perceive life events than, in a more bad way than somebody else would. So if you have illness, physical illness, and additive psychological illness, and then another, you progress with physical and somatic illness integration, then this might be more, the life event that will happen to you might be more harmful. And then there are some genetic factors, such as the promoter region of the serotonin transporter gene, and individuals homozygous for the short allele of the promoter are more prone to depression and suicide following the experience of stressful life events. And this is the stage model. Having discussed these factors, then we can understand how these authors propose the stage model of stress and disease. So some environmental demands are appraised are stressful or perceived as stressful by a person, and this leads to negative emotional response, which has, on the one hand, poor health decisions and behaviors, and on the other hand, the activation of the biological systems of adapting to the events that happen to them, and this leads to a disease-related physiological changes and to an increased risk of disease onset or disease progression. Of course, these authors say that other mechanisms may be at play, that all the stages of the models may not be required, and that potential feedback loops may exist as well. So first of all, cardiovascular disease is and its aspect is associated with life events and disease, of course, through the stress that life events may make on the organism. So when a brain is exposed to stress, the glucocorticoids increase, and there is inflammation, endothelial dysfunction, an increase in the heart rate, an increase in the blood pressure, and more oxidative stress, which will lead to the formation of atheromatosis, to the formation and worsening of atheromatosis, and of course, with some life events, myocardial infarction may increase coronary heart disease, stroke, or blood pressure control may not be such effective. Asthma is also associated with life events, and also new asthma onset on male individuals that experienced bad life events in adolescence. And of course, there was research on the autoimmune diseases such as rheumatoid arthritis and psoriatic arthritis. And as we see here, patients with psoriatic arthritis report lack of positive life events in latency, which means period 7 to 12 years, and among traumatic events during that time, psoriatic patients reported in a statistical significant way that they had witnessed trauma, they had experienced sexual abuse, alcohol or drug abuse, or other traumas. And on the chart below, we can see about how rheumatoid arthritis progresses into stages by as number of life events increase. Also, some neuropsychiatric conditions may be associated with life events, but the difficult thing is to distinguish whether the psychiatric conditions made the person most prone to some life events, or if it is the life events themselves that caused the disease onset. And this is the case of depression, dementia, the burnout syndrome, and PTSD. So, having told about mechanisms that adapt to stress, these mechanisms are almost the same when our body deals with infections. So, when we have a wear out of this mechanism, then we are more prone to infection. And the first infection to be associated with life events was the common cold. Also, there is many research on herpes zoster virus onset, the HPV and Streptococcus pneumoniae, and the HIV, mostly its progression to age. And this all happened due to immunological T-cell specific suppression by stress response. Here we can see some diagrams examining the from a meta-analysis that examines how neutrophil phagocytosis and neutrophil bactericidal activity. So we see that we have a lower neutrophil phagocytosis potential and also lower neutrophil bactericidal activity. So, briefly about the brain, because the other speakers will talk about it more. Stress is a trigger to a neuroendocrine function to aspects of behavior, such as cognition, mood, and self-regulation. So the brain responds through plasticity, which causes remodeling, mostly dendritic, which will lead in the shrinkage of some parts of the brain, such as the hippocampus and the prefrontal cortex, and enlargement of regions such as amygdala. And these were independently studied and associated with some diseases, these structural changes of the brain. So, I would like just to point out a novel approach on the oxytocin receptor. So the oxytocin is the molecule that motivates parental care, and it is believed to have stress buffering effects, moderating neural and behavioral responsives to negative stimuli, and modulating the hypothalamic pituitary adrenal axis, and to react with the cardiovascular stress processes, and also provide a faster healing in the time of lab-induced wounds. And it also promotes positive interactions with close others beyond offsprings, and it is the hormone associated with charitable giving, empathy, and compassion. So the people who express the GG genotype of the oxytocin receptor there is research that says that these people are less likely to be affected by stress and the life events that happen to them. So the basic concept is that you go to charities because it helps you too. And there was also this analysis in the oxytocin levels, and it is found that lower oxytocin levels is associated with lower stressful life events occurrence. So what are the limitations on research on the field? There is diversity of measuring methods because questionnaires are different. They measure different life durations. There is recall bias and mostly retrospective studies. There is little control for confounding factors, and there is no not extent measurement, to be accurate, of biomarkers to observe more immediate association of stress in the body. And also there is this question whether stress caused the disease or there is an underlying disease substrate that causes stress reaction and make people more prone to stress because there is little pathophysiologic, there is little knowledge on the pathophysiologic connection and the role of the brain. So the take-home message is that life events may have a considerable role in disease generation through stress. However, their specific impact on a person depends on distinct coping behaviors, age, gender, underlying pathology, and genetic factors affecting behavior. So far, life events have been associated with major human diseases such as cardiovascular disease and depression, and research on the role of life events in psychosomatic health needs a more structured global approach in order to reach strong results. So thank you very much for your attention. This is the awareness ribbon for mental health. Thank you very much.
Thank you. We will take questions at the end. So we will proceed with the second speech, which is on psychoneuroendocrinology of stress by Anna Eleftheriadis.
Dear colleagues, my name is Anna Eleftheriadi. I'm a second-year medical student at the National and Kapodistrian University of Athens. And today I will be presenting you the psychoneuroendocrinology of the stress system. But before I move on to my presentation, I would like to thank the organizing committee and especially Professor Fundoulakis for offering me this great opportunity to participate in this conference. Stress is defined as the state of threatened homeostasis, the complex dynamic equilibrium that all organisms must maintain. The first one who developed the concept of homeostasis was Walter Cannon. Walter Cannon also described the neuroendocrine response through the release of catecholamines as part of the fight-or-flight reaction. Later on, Hans Selye described the general adaptation syndrome. He was the first to describe the important role of the pituitary and the adrenal cortex in the stress response. He also named the stress-causing agent as stressor, and he also contributed by distinguishing the negative distress from the positive eustress. In this diagram by Chrousos and Gold, we can see that the stress system is mainly made up of the HPA axis and the sympathetic nervous system, as well as their interaction. So, what is a stressor? Stressors are potentially adverse forces, which can be emotional or physical. Both the magnitude and the chronicity of stressors are very important. Examples of stressors include fetal stress, loss of caretaking, natural catastrophes, sexual and physical maltreatment, medical interventions, hospitalizations, etc. It is also worth mentioning that stressors during development are very important due to neuroplasticity. The main brain systems that are involved in the stress response are the mesocortical mesolimbic dopaminergic system, the complex of amygdala hippocampus, and the propio-melanocortex system. As far as the hypothalamic pituitary adrenal axis is concerned, we see that when an organism has to face a stimuli of acute stress, the hypothalamus is activated and secretes CRH, which then acts upon the pituitary, secreting ACTH, and all this leads to the secretion of cortisol by the adrenals. CRH is a 41 amino acid peptide, and when scientists injected CRH into the cerebral ventricles of experimental animals, they saw that CRH in low doses led to an increase in glucose levels, heart rate, arterial pressure, and other parameters. In medium doses, CRH led to arousal and behavioral inhibition and the enhancement of behavioral inhibition. And lastly, they observed that CRH in high doses led to anxiety as an over-response to sensory stimuli, and also led to the decrease of environmental exploration. It is also worth mentioning that cortisol is released in a circadian rhythm. So, the dysregulation in cortisol levels is associated with many pathologic conditions. These include anxiety, depression, schizophrenia, chronic fatigue syndrome, cancer, anorexia, diabetes, osteoporosis, cardiovascular disease, obesity, and metabolic syndrome. The autonomic nervous system includes the sympathetic nervous system and the parasympathetic nervous system. The parasympathetic nervous system is responsible for the conservation of energy, whereas the sympathetic nervous system is responsible for the fight-or-flight response. The catecholamines epinephrine and norepinephrine facilitate the immediate somatic reaction associated with muscular actions. These are increased function of heart and respiration, inhibition of intestinal function, vasoconstriction, release of nutrients for muscular use, vasodilation in muscles, inhibition of tear and salivary secretion, inhibition of sexual function. So stress is a relatively stereotypic innate response that has evolved in order to coordinate homeostasis and protect an organism during acute stress. During the stress response, we observe changes both in the central nervous system as well as in peripheral organs and tissues. The central nervous system facilitates neural pathways that subserve acute, time-limited adaptive functions, and facilitates the inhibition of neural pathways that subserve acutely non-adaptive functions. During the stress response, we also observe increased oxygenation, nutrition of the brain, heart, and skeletal muscles, which are all organs crucial to the central coordination of stress response and to the fight or flight reaction. The stress response serves certain functions both centrally and peripherally. As far as the central nervous system is concerned, we observe the facilitation of arousal, alertness, vigilance, cognition, attention, and aggression. We observe the inhibition of vegetative functions and the activation of counter-regulatory feedback loops. In the periphery, we observe the increase of oxygenation, nutrition of the brain, heart, and skeletal muscles, increase of cardiovascular tone and respiration, increase of metabolism, increase of detoxification of metabolic products and foreign substances, and activation of counter-regulatory feedback loops. In this diagram, we can observe that when the activity of homeostatic mechanisms is ideal, the organism is in a state of eustasis. However, when we observe a deficiency or an excess in the activity of homeostatic mechanisms, then the organism will be in a state of allostasis. Homeostatic mediators include not only hormones, but neurotransmitters, growth factors, and cytokines. We see that, that stress and the interaction between the HPA axis and the sympathetic nervous system can affect one's behavior, growth, immunity, metabolism, reproduction, and development. The stress system responds to stressors on demand, appropriate basal activity, and temporarily tailored responsiveness to stressors is essential for a sense of well-being and adequate performance to social tasks, and is also essential for positive social interaction. However, when the responsiveness to stress in terms of magnitude and duration is inappropriate, then this might affect one's growth, development, body composition, and might be responsible for many behavioral, endocrine, metabolic, cardiovascular, autoimmune, and allergic disorders. The development, as well as the severity of these pathologic conditions, depends on the genetic, epigenetic, and constitutional vulnerability of the individual to stress, their exposures to stressors during critical periods of development, as I said before, the presence of concurrent adverse or protective environmental factors, and also the timing and the magnitude of and the duration of stress are very important. Therefore, we see that the dysregulation of the stress system might lead to mental disorders or other symptoms, and this is due to biologic and mainly endocrine mechanisms. The chronic dysfunction of the stress system is associated with many pathologic conditions. These include depression, hypotension, sleep disorders, fatigue, and hypertension. Conditions which are associated with the increased activity of the HPA axis include Cushing syndrome, chronic stress, melancholic depression, anorexia nervosa, obsessive compulsive disorder, panic disorder, excessive exercise, chronic active alcoholism, alcohol and narcotic withdrawal, diabetes, central obesity, post-traumatic stress disorder in children, hyperthyroidism, and pregnancy. Conditions which are associated with the decreased activity of the HPA axis include adrenal insufficiency, atypical depression, chronic fatigue syndrome, fibromyalgia, premenstrual tension syndrome, nicotine withdrawal, and many other conditions. You can see them here on the slide. Lastly, we see that chronic stress is linked to morbidity and mortality, and this happens due to behavioral and biological mechanisms. The behavioral mechanisms include lack of sleep, sedentary lifestyle, low adherence to self-care activities due to anxiety, depression, eating behaviors, and other conditions which are associated with the dysregulation of the stress system. The biological mechanisms that lead to morbidity and mortality include the dysregulation of the HPA axis and the dysregulation of the sympathetic nervous system. I would like to end my presentation with this quote by Voltaire. "I have chosen to be happy. It's good for my health." Thank you.
Thank you, Anna. We will proceed with the third speech, which concerns a very important question, whether stress is harmful for the brain, by Ifigenia Falaga.
Good morning, everybody. My name is Falaga Ifigenia, and I'm a fifth-year medical student in Aristotle University of Thessaloniki. The subject of my presentation, as Mr. Foudoulakis told before, is whether stress is toxic for the brain or not. Well, to begin with, stress is a normal part of human life. The stress response is intended to help humans' body react quickly and effectively to a high-pressure situation. To be more specific, experiencing anxiety, fear, and stress is considered to be normal when it is occasional and temporary, such as feeling anxious before an exam or a job interview or during a presentation. According to the American Psychological Association, 70% of Americans claim that they have experienced the physical and mental symptoms of stress, which basically means that most of people are called to deal with stress every single day. As my colleague Anna Eleftheriadis presented before, the physiologic responses for stress are well defined. Stress response includes activation of the hypothalamic pituitary adrenocortical axis and the sympathetic adrenomedullary system, which results in increased levels of stress hormones, such as corticotropin-releasing hormone, cortisol, norepinephrine, and adrenaline. These changes co-occur with other mediators that include elevated inflammatory cytokines and the response of the parasympathetic nervous system, which counterbalances both sympathetic activation and inflammatory responses. So the activation of the stress system affects various organs, such as the heart by increasing the heart rate, the kidney by stimulating the glucose release, and many others. It is obvious that this function is vital for the human survival and, of course, the human development. So the question is, could this vital function of the human body be toxic? The answer is yes. Extensive research on biology of stress now shows that healthy development can be derailed by excessive or prolonged activation of stress response systems in the body and the brain, with damaging effects on learning, behavior, and health across the lifespan. But not all stress is harmful. There are three kinds of stress, responses: positive stress, tolerable stress, and toxic stress. To begin with, we are going to discuss about positive stress, which refers to a moderate, short-lived stress responses, such as brief increases in heart rates or mild changes in the body stress hormone levels. This kind of stress is a normal part of life, and learning to adjust to it is an essential feature of healthy development. Meeting new people, dealing with frustration, getting an immunization, or overcoming a fear of animals, each can be positive stressors if a child has the support of a caregiving adult to develop a sense of mastery. Tolerable stress refers to a stress response that have the potential to negatively affect the architecture of the developing brain, but generally occur over limited time periods. This allows the brain to recover and thereby reverse potential harmful effects. For example, tolerable stress responses may occur as a result of a death or a serious illness of a loved one or a frightening accident. The presence of supportive adults who create safe environments that help children learn to cope with and recover from major adverse experience is one of the critical ingredients that make serious stressful events such as this tolerable. And now we're going to discuss about toxic stress, which refers to strong, frequent, or prolonged activation of the body's stress management system. Stressful events that are chronic, uncontrollable, or experienced without children having a caregiving adult tend to provoke these types of toxic responses. Studies indicate that toxic stress can have an adverse impact on brain architecture. In cases of severe, chronic abuse, especially during early sensitive periods of brain development. The regions of the brain involved in fear, anxiety, and impulse responses may overproduce neural connections, while those dedicated to reasoning, planning, and behavioral control may produce fewer neural connections. Extreme exposure to toxic stress can change the stress system so that it is activated more frequently and for longer periods than it is necessary. Toxic stress in young children can lead to permanent changes in brain structure and function. The plasticity of fetal, infant, and early childhood brain makes it particularly sensitive to chemical influences such as elevated levels of stress hormones, which can be pathogenic when the organism is persistently exposed to them. So, according to the fact that abundant glucocorticoid receptors are found in amygdala, hippocampus, and prefrontal cortex, the exposure to stressful experiences has been shown, 1, to alter the size and neuronal architecture, 2, causes the loss of neural connections of these areas, and 3, leads to functional differences in learning, memory, and aspects of executive functioning. Before describing the change in the brain architecture, it's really important to discuss about the elevated levels of stress hormones. As Ms. Eleftheriadis presented before, it is also, amygdala is also an activator of physiologic stress response. Significant stress in early childhood can trigger amygdala hypertrophy and result in a hyperresponsive or chronically activated psychological stress response. So, at this slide, we can see how the impaired HPA axis regulation affects the stress response. Impaired glucocorticosteroid signaling results in an attenuation of the negative feedback inhibition, which could result in the failure to sufficiently suppress CRH and AVP release from the hypothalamus, and ACTH from the anterior pituitary, which in turn leads to chronically elevated levels of cortisol. There is growing evidence from both animal and human studies that persistently elevated levels of stress hormones can disrupt brain's development architecture. Chronic stress is associated with hypertrophy and overactivity in the amygdala and orbitofrontal cortex, whereas comparable levels of adversity can lead to loss of neurons and neural connections in the hippocampus and medial prefrontal cortex. The functional consequences of these structural changes include more anxiety related to both hyperactivation of the amygdala and less top-down control as a result of prefrontal cortex atrophy, as well as impaired memory and mood control as consequence of hippocampal reduction. Because the hippocampus and PFC both play a significant role in modulating the amygdala's initiation of the stress response, toxic stress-induced changes in architecture and connectivity within these important areas may account for the variability seen in stress responsiveness. The rapidly moving field of epigenetics investigates the molecular biological mechanisms such as DNA methylation and histone acetylation that affect gene expression without without altering DNA sequence. It seems that stress turns some genes on and others off at particular times and locations in the brain, and cortisol plays a key role. Examples include regulation of the glucocorticoid receptor genes, which affects the long-term responsiveness of the brain to stress-induced cortisol release, neurotrophic receptor genes that help to alter neural architecture, and the myelin-masic protein gene, which is involved in regulating the development of the insulation on a nerve that increases the efficiency of signal transmission. A very interesting study of maternal care in rats indicates that rats whose mothers showed increased levels of licking and grooming during their first week of life also showed less exaggerated stress responses as adults compared to the rats who were reared by mothers with a low level of licking and grooming. And what is really interesting is that the expression of mother-pup interactions in the pups has been demonstrated to be passed to the next generation. Most people must be exposed to stressors in order to activate stress response. If exposure to stressors happens too frequently or goes on too long, in that case, the stress system is hyperstimulated. Stressors that may trigger toxic stress response are related to early adversity and include physical or emotional abuse, chronic neglect, caregiving substance, or mental illness, such as maternal depression, exposure to violence, and accumulated burdens of family economic hardship. One characteristic that appears to predict whether a stressor will produce a toxic stress response is its degree of controllability and predictability. Biological disruptions associated with adverse childhood experiences are linked to greater risks of a variety of chronic diseases well into the adult years. As described before, stress-induced changes in the architecture of different regions of developing brain can have potentially permanent effect on a range of important functions. Frequent or sustained activation of the brain system that respond to stress can lead to heightened vulnerability to a range of behavioral and psychological disorders. These undesirable outcomes can include a number of stress-related disorders affecting both mental health, such as depression, bipolar disorder, anxiety disorders, alcoholism, drug abuse, and physical health, such as cardiovascular disease, diabetes, and stroke. The impairment of HPA axis regulation during an acute episode is the most consistent laboratory finding in those disorders. At this study published in March 2017, the scientists measured the heart cortisol, which reflects the exposure of the child to chronic stress, and they indicated that maybe there is a combination between epileptogenesis process and hyperstimulation of HPA axis. Well, the field of genetics is a field of huge interest. A large number of case control association studies in stress-related disorders are available, focusing on a number of candidate gene systems. Taken together, there is only a limited number of studies examining the association between candidate genes and the stress response. Besides, genes involved in the sympathetic or HPA axis-mediated stress response, further genes constituting different biological system implicated in emotional regulation and neuroplasticity, such as BDNF factor, have been examined. However, the results show only moderate effective sizes, although heritability estimates suggest a strong involvement of genetic factors. GR gene has been proposed as the primary candidate for genetic association studies. Significant association between GR gene and psychological stress response were reported. Further genetic associations, not yet replicated, are reported for GABA-6 receptor subunit genes and for the MOR1 gene. Individual characteristics such as underlying anxiety, sex, age, or other biological and genetic factors and prior stress experience may increase children's and youth's vulnerability to stress. A few studies have suggested that underlying anxiety levels may predict stress reactivity, and a handful of studies identify prior stress experiences and anxiety disorders as a risk for having a worse response to new stressors. Also, chemicals involved in inflammation and neurotransmitter gamma-aminobutyric acid seems to play a role in youth's vulnerability to stress. Sex and age seems to play a role in youth's vulnerability to stress. Girls who experience harsh parenting are at higher risk of internalizing problem behaviors, and boys who experience harsh parenting are at higher risk of externalizing problem behaviors. The child maltreatment significantly predicted delinquency for males, but not for females. Their activity to laboratory stress task was higher among older versus younger adolescents. Last but not least, we should not forget the personality and the underlying stress responsiveness of each person, because everyone is unique. The role of BDNF factor in stress is remarkable, as BDNF factor is protective to neurons in condition of chemical stress, and his expression also can be really regulated in the brain by stress. To begin with, there are some information about BDNF factor. He was discovered in early 1950s, and the BDNF gene is mapped in chromosome 11. There is a widespread distribution of BDNF factor in central nervous system, and the BDNF protein expression is particularly high in the hippocampus. BDNF protein is localized to nerve terminals, and the regulation of BDNF gene expression is very important in the development of brain. BDNF factor affects on the dendritic morphology and enhances neurogenesis. Is very essential to molecular mechanism of synaptic plasticity and has been combined with pain, epilepsy, neurodegenerative disorders, neuropsychiatric disorders. These are the highlights the investigation over the BDNF factor, who has been studied for over 20 years. In 1992, Spina showed that BDNF was protective to neurons in condition of chemical stress. In 1995, Mark Smith and colleagues showed that the expression of BDNF in the brain was regulated by stress and suggested a role for BDNF in recurrent depression, aging, and post-traumatic stress disorder. In 1999, an article was published in which it was shown that in humans, early parental loss of a parent before age 9, was highly associated with the development of depression and bipolar disorder in adulthood. In 2002, Rosary and his colleagues were demonstrating that in rats, early maternal deprivation, 24 hours of maternal separation on day 9, leads to decreased hippocampal levels of BDNF after the animals reached adulthood. The authors also demonstrate that the modulation of BDNF expression in response to an acute stress was altered. It is interesting that maternal deprivation for just one day at a critical period of the animal's life has such persistent long-term effects on BDNF expression and regulation. Now, it's a fact that BDNF has survival and growth promoting actions on a variety of neurons, including dorsal root ganglion cells and hippocampal and cortical neurons. Franklin have shown that BDNF causes a significant decrease in stimulus-evoked inhibitory postsynaptic currents on hippocampal CA1 pyramidal cells. Additionally, Sherwood and Law have shown that chronic BDNF treatment decreases synaptic depression. Maternal deprivation is a paradigm that is thought to be relevant to depression. Stress reduces the expression of BDNF, especially in the hippocampus, while a plethora of antidepressants measures increased BDNF expression. This study was published in May 2017, and scientists combined a polymorphism of BDNF factor with gender and the cortisol response. They conducted a 45-minute mental stress protocol, and they found out that women with vulval genotype appeared to have a larger cortisol response to stress as compared to the med group in women, but not in men. Toxic stress is strongly associated with unhealthy lifestyles and poor mental and physical health decades later. It causes permanent effects on a range of important functions, such as regulating stress physiology, learning new skills, and developing the capacity to make healthy adaptations to future adversity. It provokes the adoption of unhealthy lifestyles, such as tobacco use, illicit drug abuse, obesity, and promiscuity, pathologic gambling, and of course, leads to inability to provide supportive relationships later in life as parents. Toxic stress in early childhood has also been shown to cause psychological disruptions that persist into adulthood and lead to frank disease, even in the absence of later health-threatening behaviors. For example, the biological manifestations of toxic stress can include alterations in immune function and measurable increases in inflammatory markers, which are known to be associated with poor health outcomes as diverse as cardiovascular disease, viral hepatitis, liver cancer, asthma, chronic obstructive pulmonary disease, and a lot more. And of course, depression. We have to keep in mind the stress-related disorders. Over and above its toll on individual, it is also important to address the enormous social and economic cost of toxic stress and its consequences for all the society. Healthcare expenditures that are paying for the consequences of unhealthy lifestyles are enormous, and the cost of chronic diseases that may have their origins early in life should be evaluated too. I'm going to close this presentation by telling you that the consequences of toxic stress prompt an urgent call for innovative strategies to reduce it. Thank you very much for your attention.
And we will conclude with the last speech, which concerns the gender effect on the stress mechanisms by Evangelia Papadimitriou.
Ladies and gentlemen, good morning. This is Eva Papadimitriou, and I'm a senior medical student. Today, for the next half hour, I'll be talking to you about the ways stress affects men and women, about the similar or different ways they conceive it, live with it, deal with it. So, let's get started. In Eastern cultures, stress has been viewed as a disturbance of the inner peace. Western cultures, on the other hand, have viewed stress as a loss of control. Nowadays, stress can be defined by physiological and behavioral responses to a real or interpreted peril, threatening the integrity of an individual either physiologically or psychologically. One's gender is an unquestionable health determinant, for there is a clear pattern indicating that the susceptibility to certain conditions, both mental and physical, is in fact sex-related. When it comes down to strain, the female prevalence is more or less apparent. Women are relatively more likely than men to report feelings of irritability, fatigue, lack of motivation, anxiety, sadness, headaches, indigestion, muscular tension, changes in appetite, and welling up as a result of stress. Men, in contrast, are more likely than women to report no symptoms of stress to their therapist or social circle. In a sample of 1,226 subjects, when men were questioned, 36 denied having been affected by stress physically, and 40% denied having been affected by it mentally. In comparison, only 26% of the women denied having been affected by stress physically, and 32% mentally. Contradictory, 88% of the women admitted that stress had a strong impact on their lives, while 78% of the males admitted to the same thing. Like in the previous slide, we see a 10% divergence. So, the logical question to ask is this: are men less affected by stress, or are they having a harder time than women recognizing its symptoms and or expressing their hardships to other people? Before answering, I feel it is important to consider the 2015 study of Joel et al. At Tel Aviv University that used an interesting and thorough approach to compare the structure of male and female brains. Researchers looked at brain MRI scans of more than 1,400 people. They compared anatomical brain features that are known throughout studies to be binary. These are the hypothalamus, the nucleus of the preoptic area, the preoptic anterior hypothalamus areas, the posterior medial part of the bed nucleus of the stria terminalis, the central nucleus of the BST, the suprachiasmatic nucleus, and the anterior commissure. The 5 first are known to have a larger size in males, while the last 2 have been found to be bigger in females, as indicated by the studies of Swab and Huffman, Swab et al., Allen et al., Allen and Gorski, Tu, and many more. To continue, Joel et al. Reached the conclusion that out of 1,400 participants, 94% demonstrated a mixture of both male and female brain characteristics, regardless of the gender. Only 6% of the participants possessed solely those brain characteristics their gender would imply they would have. Overall, the findings suggest that human brains do not belong in one of 2 distinct categories. Although a lot more research needs to be conducted here, and even though hormones influence brain development even in the womb, research suggests that before age 13, boys and girls' mental circuitry appears to be similar. Also, a lot of gender differences emerge during reproductive years and gradually diminish after menopause. All of the above suggest that the sex hormones, alongside the family, culture, and general conditions that one has experienced, shape the brain features as well as its reactions to stresses. So, in order to answer our question, we need to further our inspection to health issues commonly triggered by stresses and to what extent they affect the genders. That being said, susceptibility to infectious diseases, hypertension, type 2 diabetes, heart attack, aggressive behavior, and drug abuse is generally observed to be higher in men. All the above conditions are listed as physical reactions to stresses, especially when there is also a genetic background. For instance, an analysis of results from the National Survey on Drug Use and Health of America indicate that in 2011, as in prior years, the rate of illicit drug use amongst individuals aged 12 or older was higher for males than for females. Male percentages were higher for several different illicit drugs, including marijuana, cocaine, and hallucinogens. Also, in 2011, an estimated 57.1% of males aged 12 or older were current drinkers, which was higher than the rate for females. We can clearly see the 10% divergence here as well. It was noted, though, that males and females aged 12 to 20 had similar rates of current alcohol use, for about 23%. However, boys were more likely than girls to report binge or heavy alcohol use. It is likely so that males tend to actively engage in self-centered, self-destructive behavior when faced with stressful situations, and we'll keep that in mind for later. On the other hand, autoimmune diseases, chronic pain, depression, and anxiety disorders are more prevalent amongst women. The statistics of the American Autoimmune Related Diseases Association prove that. On the graphic, we can clearly see how much bigger the pink lines for women are comparing to the blue lines for men. On the graph, such as Graves' disease, rheumatoid arthritis, Hashimoto's thyroiditis, multiple sclerosis, lupus, and Sjogren's syndrome. On the next graphic, we see the prevalence rates for anxiety disorders among men and women, where we can observe that 8% of women report suffering from one or more anxiety disorders, comparing to just 3% of men. To get to the bottom of this, we should consider the pathophysiology of chronic stress symptoms. Between a stressor and the strain it causes, two systems stand. The hypothalamic pituitary adrenal axis, aka the HPA axis, through which cortisol is released, and the sympathetic nervous system that releases catecholamines. Research by the Association of Industrial Psychiatry of India has shown that both the autonomic nervous system and the HPA axis are stimulated differently between the two genders, with men demonstrating greater acute HPA as well as autonomic responses. The assessment of gender differences in stress reactivity relies primarily on measuring the physiological responses to acute stresses. In 2005, the survey of Rubinoff et al. Was published, during which 4 groups were formed, 2 of men and 2 of women. Gonadal suppression with leuprolide acetide was induced, a monthly intramuscular injection of 7.5 milligrams in men and about 4 milligrams in women. Pharmacological through CRH and physiological through exercise stresses were imposed on the subjects, and the HPA axis response was measured and compared. With the conclusion of the survey, it was observed that CRH-stimulated ACTH, exercise-stimulated cortisol, and exercise-stimulated ACTH were all significantly greater in men than women. but CRH-stimulated cortisol. So, despite the absence of sex differences in estradiol or testosterone at the time of testing, since hypogonadal conditions were used, men showed increased stimulated ACTH and cortisol compared to women. This genesis of cardiovascular disease, aggression, and immune suppression is higher in men. As far as women are concerned, estrogens weaken the sympathoadrenal and HPA responsiveness, leading to slow cortisol feedback and thus delayed containment of the stress response. The greater rates of women developing depression compared to men are related to this sluggish cortisol feedback on HPA arousal, which leaves cortisol to affect the body for a longer time. An increased HPA axis response to stress in females is observed in neonatally gonadectomized rats, but in no way does it reach the high levels of the male response. As stated earlier, this is independent of differences in circulating gonadal steroid levels. This suggests an innate difference in the HPA axis response to stress. Genomic differences, effects caused by neonatal differential gonadal steroid exposure or effects of recent gonadal steroid exposure are some of the possible underlying mechanisms reflected in the observed sex differences in the central nervous system function. When focusing on the psychoneuroimmunological field, we found out that the HPA axis acts as a regulatory feedback loop that shuts off inflammatory responses to invading antigens after the initial response or in a state of stress. The increased HPA response in men leads to acute high concentrations of glucocorticoids, which shift the cytokine balance towards a Th2 response. Humoral immune responses are favored, while cell-mediated immunity is suppressed. Glucocorticoids specifically inhibit the production of pro-inflammatory cytokines, such as interleukin-6, 1, and tumor necrosis factor alpha in monocytes and macrophages. The anti-inflammatory cytokines, such as interleukin-4, 10, 13, IFN-A, and TGF-beta, remain unaffected though, and are even stimulated. Estrogens induce a shift in cytokine balance towards a Th1 response, thus activating the aggressive Th1 and Th17 arms of the immune system. Adding that to the fact that women produce more CD4 T lymphocytes and larger amount of pro-inflammatory cytokines, it is clear that female sex hormones stimulate inflammatory pathways which can exacerbate autoimmune conditions, as stated earlier in this demonstration. Notably, many multiple sclerosis therapies work by reducing Th1 or Th17 responses, thus countering estrogen's effects. However, progesterone has a competitive binding to the glucocorticoid receptor, inhibiting pro-inflammatory cytokine production. During neuroimaging studies, achievement task stressors caused asymmetric prefrontal activity in males and limbic activation in females. The right parietal frontal cortex plays a major role in regulating negative emotions. It moderates and inhibits dorsal anterior cingulate cortex and amygdala hyperactivities associated with negative emotional behavior. Persistent dorsal anterior cingulate cortex activation was observed in female subjects, possibly predisposing women to mood disorders and depression if not regulated by the right parietal frontal cortex and amygdala. Studies by Asari et al. Of University of Michigan in 2016 indicate that although women are more likely than men to report strain during the time when the stressors occur, it is men who are actually at greater risk of developing clinical depression as a response to stressful life events 25 years later. They concluded that the serotonin 5-HTT-LPR-S allele and mental health responses to SLEs are associated, and men with the LL genotype with great exposure to SLEs are at the highest risk of eventually developing clinical depression 25 years later. Furthermore, twin or family studies have shown that personality traits, childhood adversity, genetic background for depression and anxiety, concern for approval or terror for disapproval, interpersonal problems with one's proximal network, and ruminative thinking are some of the factors known to increase sensitivity to SLEs to both genders equally. Apart from SLEs, though, we should take the Bowlby's attachment theory into consideration, which is based on the premises of a child's desire for proximity to its mother, being a biological drive selected by evolution to increase the infant's probability of survival. An insecure attachment may increase perceived stress. Also, it may increase the intensity or duration of the physiological stress response. Although men and women have very similar stress triggers, their behavioral responses are quite different in a way that is linked to gender. University of Vienna psychologist Livia Tomova and her team have found that men tend to take a very egocentric approach when responding to stress. Men adopt a fight-or-flight response when they prepare themselves to deal with stress by conserving their energy and ignoring the perspectives or needs of others. Women, however, adopt a tend and befriend approach through which they try to better understand the other people's perspectives or the reason why the stress is present. They begin to question themselves as to why they are feeling stressed and try to recognize variances in other facial expressions, while for men, stress can only see neutral or angry faces when faced with stresses, thus triggering a more negative and aggressive response to stress. Tomova et al. Claim these responses to stress to be a result of evolutionary past. Women wanting to protect the offspring and themselves lay low with other members of the kin, choosing strength in numbers rather than heading out to danger. They saw the benefits of creating a social support system or befriending the enemy, allowing them to talk the stress away, and in turn, better understand and respond to it. A 2012 study by Australian researchers Jo Yong Lee, Vincent Harley, and Daniel Check determines that there may be a single gene responsible for how men and women respond to stress. The SRY gene that men have on the Y chromosome contributes to the release of norepinephrine into the bloodstream, leading to an increase in blood pressure that encourages the fight or flight response. Women, on the other hand, do not have the SRY gene and instead secrete endorphins that motivate them to behave in a friendly manner towards the proximal circle and facilitates the tend and befriend response. It is, of course, important to note that these responses become a bit more complicated depending on one's idiosyncrasy. The Association of Industrial Psychiatry of India suggests that stress responses in men may be primarily characterized as fight or flight due to the observation that in the male brain, the right parietal frontal cortex is activated and the left orbitofrontal cortex deactivated in a predominant way. As stated earlier, the right parietal frontal cortex is an important part of both the negative emotion and vigilance systems, while the left orbitofrontal cortex is associated with positive emotion and hedonic goals. Involvement of the limbic system, including ventral, striatum, putamen, insula, and cingulate cortex, underlies the stress response in females. The observed limbic activation due to stress in female subjects is more consistent with a tend and befriend rather than a fight-or-flight model. As we reach the end of this presentation, the only aspect left to discuss is how the genders manage to cope with their stress. In the 2011 survey of the American Psychological Association, 1,226 subjects were asked whether they feel they are doing enough to manage their stress. The great majority of men responded affirmatively. Only half of the women responded affirmatively, while a quarter of them gave a negative response. As for the ways the genders choose to cope with stress, males prevailed at listening to music, watching movies or television, playing video games or surfing the internet, spending time doing a hobby, drinking alcohol, smoking, playing sports, or doing nothing at all. Females, on the other hand, resort to exercise, spending time with friends or family, reading, praying and going to church, sleeping, eating, shopping, getting a massage, meditating, or seeking professional help. Lastly, both genders equally fall back on gambling or are unwilling to do any activity. All in all, the neurobiological substrates of why the genders react differently to stress continue to be explored. In the future, as our research furthers, we will hopefully be able to prevent the various disorders stemming from SLEs that today require our intimate care. Thank you very much for your attention. I hope you enjoy the rest of your stay here and have a safe journey back home.
So we have time for a couple of questions, if there are any. This was a symposium which included only medical students, and I think the quality level was rather impressive for the level of the speakers, unexpectedly high. Thank you. So, are there any questions? I think Uriel will surely have a question. No?
Well, I don't have a question. I just want to congratulate you, the supervisor.
Well, limited supervision, you know. Thank you. So if there are no questions, we will give the floor to the next symposium. Thank you all.
examination. But until the 90s, insight had often been measured as a unitary phenomenon, and the studies of insight in schizophrenia classified patients as having either good or poor insight on the basis of whether or not the patient denied he was disturbed. This approach to using the assessment of insight is categorical, and according to that, insight is viewed as an all-or-none phenomenon and fails to capture the complexity of insight demonstrated by the patient. Instruments that measure insight in patients who suffer from schizophrenia usually contain items that assess not only the patient's awareness of having a mental disease, but also their appreciation for necessary treatment and whether they attribute any of their perceived symptoms to a mental illness. Measurements of insight have been shown to correlate with other aspects of symptomatology, treatment compliance, and cognitive impairment. Standardized and evaluated tools for the assessment and quantification of insight have been developed over the past 25 years. The scales that are shown here have demonstrated good psychometric properties, so this lecture will be focused on the dimensions and factors which have been revealed from their analysis. We are going to talk about the schedule for assessment insight, the PSI and PSI expanded, the scale to assess the awareness of mental disorder, the insight and treatment attitude questionnaire, the Birchwood self-report insight scale, the self-appraisal of illness questionnaire, the Beck cognitive insight scale, the measure of insight into cognition, and the Vegas, clinician-rated and self-reported versions. The assessment of insight is incorporated in many clinical scales. The positive and negative syndrome scale, the widely known as PANSS, has one insight item which is included in general psychopathology scale, and it's the item 12 in this scale, the general psychopathology scale. The schedules for assessment insight can be divided into three categories: the clinician rated scales, the self-reported scales, and the scales who have both of these versions. We're going to talk about the clinician-rated scales, and first of all, PSI, the Schedule for Assessment Insight. It was early 1990 when suggested by David, as we heard it before, that insight has at least three dimensions: awareness of illness, the capacity to relabel psychotic experience as abnormal, and treatment compliance. Initially, an attempt at standardizing the assessment was made which related to each side of insight, and the schedule for assessing the three components of insight, the PSI, arose. In order to measure insight according to the suggested dimensions, the following questions have to be answered. Does the patient accept treatment? This includes passive acceptance or medication, admission, or other physical and psychological therapy. Does patient ask for treatment unprompted? Do you think there is something wrong with you? Or do you think you have an illness? Do you think you have a mental or psychiatric illness? How do you explain your illness? Do you think the belief that, and here a specific delusion or hallucination is inserted, is not really true or is not really happening? And how do you explain this phenomena? Although the pattern of intercorrelations obtained support the hypothesis that insight is not a unitary construct, but one composed of two or more related but partially independent elements, the original factor analysis gave a single factor solution. And here we have, PSI expanded. PSI expanded is an 11-item semi-structured interview, comprises questions to assess the three dimensions of insight: awareness, labeling of symptoms, and treatment compliance. Plus, here is the item 9, plus a hypothetical contradiction item added to evaluate the person's capacity to consider another's perspective. This expanded version also includes items on awareness of change, difficulties resulting from the mental condition, and insight into key symptoms. At least 2 studies yielded 3 factors from their factor analysis of psi expandent. Factor 1 consisted of the 2 symptom relabeling items. Factor 2 consisted of the 5 awareness of illness items, and factor 3 consisted of the 3 treatment compliance items. But because of the high item intercorrelations of the scales, factor analysis might be not the ideal method to assess the internal structure of these scales. It has been suggested that statistical techniques based on dissimilarities perhaps would be a better method to detect the insight components. The evaluators of the Greek version of psi expanded used a method based on dissimilarities, and they found 2 underlying dimensions within the insight construct. The first dimension lies on a continuum of insight from mere awareness of illness to treatment compliance via relabeling of symptoms. The second dimension represents 2 poles of insight, spontaneous pole and induced pole. Spontaneous pole is related with spontaneous request of treatment along with awareness of psychological changes and relabeling ability. On the other hand, acceptance of proposed treatment, along with awareness of clinician explained need of treatment and awareness of the social consequences, lie closer to the induced pole. The induced pole refers to the perceived need for treatment on the basis that some patients accept treatment without acknowledging illness and vice versa. The ITAC, Insight and Treatment Attitude Questionnaire. The guiding concept here is that patients with insight judge some of their perceptual experiences, cognitive processes, emotions, or behaviors to be pathological in a manner that is congruent with the judgment of involved mental health professionals, and that these patients believe that they need mental health treatment, at times including hospitalization and pharmacotherapy. This is a structured open interview which includes 11 questions assessing attitudes towards past and present illness and towards past, present, and future treatment. So we have here 11 items related to awareness of illness, awareness of need for treatment, attitudes towards treatment, and attitudes toward the use of medication. The ITAC has been criticized as not being truly multidimensional, because it consists of only 2 dimensions, awareness of general mental illness and treatment compliance, with 8 of its 11 items mentioning treatment and 6 of these items specifically measuring treatment compliance. Also, again, a single factor extracted from the analysis. The SUM, the scale to assess unawareness of mental disorder, is a semi-structured, again, interview scale that attempts to assess present and past awareness of illness. It's one of the most widely used instruments with satisfactory psychometric properties to measure insight while considering the multidimensional and continuous approach. The first 3 items assess in turn the subject's basic awareness of illness in the present and in the past, the effects of medication upon the illness in the present and in the past, and a general understanding of the social consequences of the illness, again, in the present and in the past. So we have here 3 rows and 2 columns that makes 6 general items. Here we have 4 subscales for awareness, current awareness, past awareness, current attribution, past attribution, and we have with 17 items each of it. This scale requires that the subjects have a mental disorder with one of these 17 symptoms listed here. For each symptom item of the scale, it must first be ascertained that the subject has the particular symptom during the period under investigation. The severity of the symptom is not relevant, only that it is clearly present. The subscales assess, in the current column, the highest level of awareness obtained at the time of the interview, and in the past column, the present level of awareness for each item occurring during the period of time preceding the current period of investigation. Following each symptom item, the clinician is asked to rate the subject's understanding of the cause of the symptom, and we are talking about attribution here. For any symptom, attribution items are rated only if the subject received a score between 1 and 3 on the awareness item. So, we have 6 general items, 4 subscales with 11 items each. That counts for 10 scores and 74 items. Factor analysis coming from another study 13 years later from the original one, revealed 3 factors. General lack of awareness of having a mental illness, lack of awareness of the significance of medication, and lack of awareness of specific symptoms to the illness. It is usually used in clinical trials and epidemiological studies, but more rarely in clinical practice because of its length. So, an abbreviated form was constructed, and the first 3 items reflect the awareness of illness, the other 3 reflect the awareness of positive symptoms, and the last 3 are representative of awareness of negative symptoms. About self-reported scales now. So far, studies of insight and schizophrenia have used researcher-rated insight scales rather than self-report instruments. Perhaps this is because it is assumed that a self-report instrument is incapable to capture the way that people with schizophrenia understand and feel about their illness. Here we have a scale which can be administered quickly and without interview or rater assessment. It's a brief self-report assessment questionnaire that it is acceptable to acutely ill patients and can be completed quickly. It contains 8 items that are grouped into 3 subscales. Those subscales are the awareness of having a mental illness, the proper attribution of symptoms, and the appreciation for necessary treatment. It is constructed to measure gradations of changes in insight during recovering from acute psychosis and has the ability to discriminate individual differences and individual change over time. But again, the factor analysis yielded only one single factor. The self-appraisal of illness questionnaire. This scale is a self-administered instrument designed to evaluate attitudes toward mental illness among patients receiving treatment. It was developed to be used in community settings. It is an instrument composed of 17 items. Higher scores indicate greater denial of illness and of need for treatment and less worry. How much do you worry about your condition? How much do you worry about getting into trouble because of your condition? Representative items. The content of many of the psych items is similar to the content of structured interviews used to assess insight. The items address acknowledgement of illness, beliefs about the outcome of illness, acknowledgement of a need for psychiatric treatment, and extent of worry about illness and about illness-related issues. 3 factors extracted from the analysis: need for treatment, worry, and presence of illness. Unexpectedly, the worry subscale was not consistently related to either of the other subscales or to clinicians' assessment of participants' insight. Perhaps worry of illness is a component of insight not traditionally considered by clinicians and represents psychosocial outcome. Individuals with no awareness of illness cannot worry per se about their illness. Therefore, the worry subscale may be inappropriate for use with people with little to no insight. And here we have the Beck Cognitive Insight Scale. So far, the approach focuses on patients' awareness of several attributes. For example, does the patient recognize that he's suffering from a mental illness, that his symptoms are pathological, that he needs treatment? But as pharmacological and behavioral therapies become more widely available, it will be important to know if patients do really understand the need for the treatment. So far, only the clinical concept of insight had been evaluated by a variety of scales, most of them presented here. However, the clinical-oriented scales do not directly address the patient's capacity to evaluate their anomalous experience. Cognitive insight includes the evaluation of distorted beliefs. During assessing cognitive insight, the aim is to evaluate patients' objectivity regarding delusional beliefs, their capacity to reattribute previous incorrect and wrong explanations, and their capacity to correct information coming from other people. It contains two sets of items, two components. The first component is relevant objectivity, reflectiveness, and openness to feedback. Using other words, patients' capacity and willingness to observe themselves and to consider alternative explanations. That means to recognize that they could be wrong even when they felt strongly that they were right, that other people may be more objective than them, and that they are willing to consider another people's comments about them, that their experiences and ideas that had seemed to be real were due to their imagination, and some of them were due to their stress. The second component reflects patients' certainty about being right, resistance to correction. That means their overconfidence in their validity of beliefs. Two scales which have both clinician-rated and self-reported versions. The first is the measure of insight into cognition, the MIC. Helps us to understand if people with schizophrenia have insight into their cognitive deficits. They are focused on attention, memory, and executive function, which are the neurocognitive domains most commonly impaired in people with schizophrenia. They are based on the SAMT and measure the degree of insight into cognitive deficits from a multi-phased perspective, examining awareness of cognitive deficits as well as the attribution of cognitive deficits to mental illness. A factor analysis, again, demonstrated one large factor containing all the 12 items, and as well as two much smaller factors. But it appears that the items of this scale are highly interrelated and correlated with one another, and individuals with schizophrenia tend to perceive cognition as a unitary construct without necessarily clustering skills into the commonly recognized neuropsychological domains. And here is the vagus. Easy to use, easy to administer of a measure of insight into illness in persons with schizophrenia. It's very easy to find it online, a 10-item self-report version and a 5-item clinician-rated version. Both scales are efficient, each taking approximately 5 minutes to be completed, and the subscales of insight that were developed here were general awareness of illness, awareness of need for treatment, awareness of negative consequences, and symptom attribution. Both versions appear to build on previously developed insight scales in terms of its multidimensional factor structure. It's ideal for intervention studies with rapidly acting medication because of its capacity to detect small changes. Again, one factor yielded from Vagus clinician-rated version and 3 factors yielded from Vagus self-reported version. What should we use? Clinician-rated scales or self-reported scales? Interview techniques require more time to administer than self-report methods and are complicated by the issue of inter-rater reliability. The development of a self-report questionnaire would be more convenient and may eliminate potential clinician biases, such as the tendency we have the clinicians to rate patients with either lower general intelligence or fewer communication skills as having poorer insight. Similarly, the patient's responses may be biased by the presence of an examiner and the interaction that takes place between them. This may be particularly true for schizophrenic patients, given their common difficulties with interpersonal interactions. Self-report scales might have the benefit of obtaining the same information in less time and provide a better control for this confounding variable that refers to the interpersonal interaction. So, finally, we can say that insight into having a mental disorder is a complex phenomenon with a number of component dimensions. The component dimensions of insight are continuous rather than dichotomous phenomena. In other words, one can have partial insight. Continuous approaches based on multidimensional models, on the other hand, include several dimensions with different ways of assessing and scoring them. And it is of great importance to assess separate domains of illness awareness. Patients often deny that they have an illness, but admit to the benefits of medications. Or they might recognize the presence of abnormal symptoms, but yet deny that the problem is illness-related. This phenomenon reveals a weakness in global scoring methods. It stresses the importance of assessing separate domains of illness awareness. Level of insight can vary across the many manifestations of illness. For example, a patient may be aware that he or she has flat affect, but be totally unaware of his or her sociality. In terms of future research, it would be of benefit to explore the effects of self-report assessing, utilizing different examiners and different settings, and to explore the effects of which is the appropriate method to study insight without perhaps using factor analysis, which is based only on correlations. Thank you very much.
Thank you, Dr. Arvaniti, for your detailed talk. Our next speaker is Dr. Georgios Avram, who is a psychiatrist, who is a PhD candidate in the Demokritos University of Thrace, Greece. The title of his lecture is Explanatory Models Concerning Impaired Insight in Schizophrenia.
Hello, good morning, everyone. I want to thank Professor Samakouri, and today we're going to talk about models concerning impaired insight in schizophrenia. Poor insight, lack of awareness of illness. It's been commonly observed among 50 to 75% of individuals with schizophrenia spectrum disorders, as mentioned earlier. Poor insight reflects an awareness of many aspects of the illness, as described by clinical insight. And these three components of clinical insight, as mentioned earlier, the recognition that one has a mental illness, the ability to relabel unusual mental events, and recognition of the need of treatment. The point of this slide is that all these three seem to require a degree of executive functioning capability. So in a way, clinical insight, as defined here, has a component of impairment in executive function. Amador added two more elements there and other stuff about things. And cognitive insight, as introduced by Beck, 2004, is the account for this capacity. He developed the concept of cognitive insight, which is very important later for the models that we will say. The cognitive insight has two domains, self-reflectiveness and self-certainty. And it shows that psychotic patients expressed not only consistent distortions of their experiences, but also an inability to distance themselves from these distortions. So in a way, there's no ability to correct the feedback. Cognitive insight is a construct referring to the ability to evaluate abnormal experiences and recognize incorrect interpretations. Some other comments about insight. I'm going to try to make a long story short, talking about difficulties for developing models and describing some models that are developed. The difficulties for the insight models is that poor insight is not an educational deficit, nor a global unawareness of the world. It's a particular form of unawareness, and a model of poor insight must thus be able to explain a disturbance in awareness of psychiatric illness. People with poor insight may respond in a fully adaptive manner to other life demands, meaningfully appraise their own physical health, recognize the symptoms of others who are mentally ill, but not their own. The first model that was developed was the psychological model, and denial is the key word. Psychosis is seen by many, and it is, a chronic, lifelong, debilitating disorder with little chance of recovery. As such, a diagnosis of psychosis can be viewed as a threat. Some individuals use denial to help them to cope with this threat and reduce the amount of distress. So poor insight the psychosis may reflect the use of psychological coping mechanism. McGlasson called this coping strategy sealing over, while Beechwood suggested that impaired insight is a process of denial to cope with the negative consequences of illness. So those who deploy denial as a coping strategy will have poorer insight, but will suffer less distress and will maintain a greater degree of self-esteem. So there's something to gain there. Distress is also another key word for the psychological model. So the use of denial as a coping style has a hint that maybe it's connected to executive function, because coping style and executive function are linked. After that, the psychological model tried to link depression and suicide with insight. These two studies say that there is a chain of causality from insight from more insight to depression and to suicide. But this was too good to be true, and of course, current knowledge on the relationship of insight to depression and suicide is inconclusive. It's not that easy. So insight, on the other hand, is described by neuropsychology as a result of cognitive deficits that appear as a consequence of dysfunction in neural processes in frontal and parietal regions. Amador said his famous anosognosia, suggesting that lack of insight in schizophrenia is similar to anosognosia in neurological disorders, which is a brain damage. So the emerging models had this bipolar thinking about insight. Literature had seemed more or less stuck in determining whether poor insight was a cognitive deficit or a defense mechanism. But more recently, there's been extensive criticism on this paradigm, and insight, we think, is a complex phenomena involving not only the acceptance of a single fact, take it or leave it, but the integration of a range of experiences into a complex, personalized understanding of psychiatric challenges. Osatuke in 2008, in this review, tried to link everything that was related to insight and found that there's positive symptoms, negative symptoms, disorganized symptoms, denial and defense was linked, biological model, cognitive error, neuropsychological models, conceptual organization, abstract thinking, executive function, and metacognition. So we're going to talk about some of these elements, starting with symptoms. The first two studies show that there's a link between psychiatric schizophrenic symptoms and insight, while the two others say there's not. So in this review, we see that relationships have not been consistently found. It's not that there is not a link between symptoms and insight. It's just, as explained in this review, that symptom severity may sometimes affect insight for some persons in some conditions. So in order to have a model for insight, we have to take into account these things. That insight requires awareness of changes in internal states, awareness of the perception of others, recognition of the details of pertinent historical events, judgments about the causal links between historical events, and finally, a synthesis of them all into a coherent representation and a coherent action plan. So the current suggestions about building a model for insight suggest that poor insight is shaped and sustained by multiple forces, which include deficits in neurocognition, social cognition, metacognition, and high levels of stigma. All these four are semi-independent factors that have been identified it's a very nice period, have been identified that might affect parts of the chain of mental activities required for insight. So it's so complex that we're very careful about putting it in words. The first element that I mentioned earlier is neurocognition. Deficits in neurocognition in this study says that there's a deficit in verbal memory and cognitive ability in people with poor insight. Another study connecting executive dysfunction with insight. Another study talking about episodic memory and semantic memory and insight. One common interpretation across studies is that with deficits in memory and executive function, it is more difficult for individuals to recollect the various historical events related to mental illness and piece them together into a coherent and insightful account of their own mental illness. Imaging studies have found that dysfunction in the cortical areas is also linked with insight, as seen in this study. Another review here, which connects insight with abstract thinking and executive function. Here in this not-so-good slide, we see all the studies investigating the anatomical abnormalities of insight. It's taken from this big review. Several studies have indeed suggested that the lack of insight in schizophrenia spectrum is related to structure. Abnormalities related to insight include reduced total brain volume, ventricular enlargement, frontal lobe atrophy, reduced frontal volume, and gray matter deficits in the cingulate, precuneus, temporal, and parietal lobes. Neuroimaging approaches support a neurological etiology of insight deficits in schizophrenia and suggest that the multidimensional construct of insight has multiple neural determinants. So deficits in attention, memory, executive function might limit the person's access and ability to sort out the pieces of information which can be later assembled into a coherent account of psychiatric challenges. The second is social cognition. Social cognition has 4 elements: the theory of mind, the emotion processing, social perception, and the biased attribution. Social cognitive abilities are necessary to be able to gain additional perspective on events from the view of the other. It helps to interpret the social stimuli, and these are the areas of the brain that is linked. A special theory of mind refers to the cognitive ability to understand one's own and others' thought processes. The extant literature indicates that patients with psychosis all exhibit TOM theory of mind impairments. This study says that theory of mind deficits negatively affect insight independently of neurocognitive deficits and symptom severity in schizophrenia. Another fMRI study so the link between theory of mind and insight has yielded inconsistent results, with some studies showing association with clinical insight and some with cognitive insight. As seen, for example, here, there are 2 interesting studies, where the first one from Popolo in Italy says that after controlling for symptom severity, one's ability to understand the intentions of others is related to cognitive insight, but not clinical insight. And the same year, 2016, another study, clinical insight is related to theory of mind ability. But it doesn't matter if there's differences, there's a clear link between theory of mind and insight. The third is metacognition, the third factor. It refers to a spectrum of activities that involve thinking about thinking. Stretches from consideration of discrete psychological phenomena to the synthesis of discrete perception into an integrated representation of self and others, being able to think about how you think. It is thought metacognitive processes that persons are able to discern their own cognitive abilities and knowledgeably apply them in appropriate situations. While metacognition may be associated with neurocognition that we mentioned earlier, it's different. neurocognition refers to more general cognitive capacities. Metacognition refers both to implicit and explicit understanding of knowledge about one's own and others' thought processes and internal states. So it's much more complex in a way. In this study, Lissaker reported that a lesser ability to form a complex representation of oneself is uniquely linked to poorer insight after controlling for deficits. Consistent with these findings, imaging studies suggest that good insight is correlated with greater functionality in brain regions which support self-consciousness, self-other distinction, and self-referential processing. Another study connecting the precuneus with, and there's stigma, the fourth element. Stigma has always been a barrier. In this study, we see that stigma is a significant predictor of insight. Another study shows indirect evidence connecting stigma and insight by treatment targeting self-stigma improves insight as well. So it's an indirect evidence that stigma is connected with sight as well. Improved insight has been linked to emotional distress. With greater insight, people have greater levels of depression, lower self-esteem, and decreased quality of life. So after the psychological model, depression came again and is linked with insight. Stigma and depression, other studies that link stigma and depression that are important. Cognitive insight is significantly related to mood and schizophrenia, so is clinical insight. And now I want to say some key issues about what I've already mentioned. Individuals with schizophrenia gain awareness of illness, they may be increasingly vulnerable to depression, low self-esteem, and hopelessness. Poor insight is a result of a range of factors, including the four things that we mentioned: neurocognition, social cognition, metacognition, and a wish to avoid stigma. In general, poor insight remains resistant to treatment, and there are several promising approaches that address insight in an integrative fashion that are in an early stage of development and take into account the role of deficits in neurocognition, social cognition, metacognition, and self-stigma. One of these is this from 2014, tries to connect self-stigma, negative symptoms, insight, hope, and depression. As you can see, the more insight, less hope, and more depression. It's conducted with 284 people by SRANK. Another model trying to link a positive relationship between mood and self-reflection and self-certainty, the two components of the Beck's inventory. And another one that tries to connect all these that we mentioned earlier: neurocognition, social cognition, metacognition, and stigma. So to conclude, poor insight into schizophrenia is a multidimensional construct that involves unawareness of a range of aspects of mental life. It is of vital interest that it's closely linked to a range of poor outcomes, but it's also linked with a reduced risk for depression. Recent work has suggested that poor insight reflects difficulties integrating a range of information into a coherent account of the challenges of a serious psychiatric illness, rather than the rejection of a fact, take it or leave it. One long-standing barrier to addressing insight has been this bipolar tendency to regard poor insight as either an educational deficit resulting from impaired cognitive processes or a defense mechanism of denial. If poor insight is merely the lack of information or the resistance to that information, it's difficult to see how treatment could do more than supportively attempt to provide information. Most recently, more complex models of poor insight have emerged and have framed poor insight as more than getting the facts wrong, offering an account that could explain why this form of unawareness could develop in individuals aware of so many other aspects of life. And finally, we have to think of insight as a concept of a failure to create a sufficiently complex and adaptive presentation of oneself as struggling with life-altering psychiatric challenges. By framing good insight as the successful integration of different life experiences into a coherent narrative, we have to focus on these four elements: the deficits in neurocognition, social cognition, metacognition, and stigma. And this view also may explain why just providing information is not necessarily helpful. I hope you became more insightful about insight. Thank you.
Thank you, Dr. Avram. Our next speaker is Theophanis Vorvolakos, who is a psychiatrist, assistant professor in psychiatry, Demokritos University of Thrace, Greece. The title of his talk is Consequences and Treatment Approaches of Insight Impairment in Schizophrenia.
Hello, thank you everyone for being here, and I would like to thank the organizing committee for its invitation. We will talk about, although there are not many things left to be said from the previous speakers, but we'll talk in a more practical manner about the consequences and potential treatment approaches in order to deal with insight impairment. As it mentioned before, insight is quite common in schizophrenic patients. About 50 to 80% do demonstrate some insight impairment when the disease begins. It's a multidimensional concept, as it mentioned and thoroughly analyzed before, so it's not binary, either have it or not. It has many aspects, and that's the main challenge we have to deal with. And also that makes it this multidimensional and abstract nature of it makes it difficult to assess and treat, because there is no sufficient consensus regarding the nature of the symptom, and B, because it's difficult to assess it and design studies about its causes and its and intervention to deal with it. Nevertheless, no one really doubts that it does have serious implication in the course of the disease, and mainly it affects the adherence to treatment. We'll talk about it in a while. It can cause depression in various ways, which, as Dr. Avram pointed out, it might prevent from depression in some cases, but it might cause depression or depressive behaviors in later stages of disease, and is also related with violence, either self-directed violence or other directed violence. As a result, no one really doubts that since it's a symptom and that affects the course of the disease, the presence of it does affect the outcomes of schizophrenia, which are getting poorer when insight is not dealt properly. Treatment adherence, that's the most studied aspect of insight, lack of insight consequence in the course of a disease, because it's linked many times. Poor insight is linked quite often with less adherence to treatment, and that makes it quite an important goal, quite an important symptom to deal with it. Although its great variance of poor adherence is attributed to lack of insight or insight impairment, we should always think that this is not the only reason that someone might be not that adherent to treatment. There are other reasons also, like side effects of medication. So someone might be insightful about his schizophrenia, but still not be able to tolerate some side effects. So treatment adherence, although it is affected by poor insight, doesn't mean that whoever is not adherent has great insight impairment. On the other hand, people that adherent to treatment and has good insight in their vulnerability tend to be more able to tolerate side effects or the fact that they do take medication because they view themselves as vulnerable and they believe that medication can strengthen them. But we should be careful about it because having some insight or this belief that you are vulnerable due to your disease doesn't mean that your views are the same with the therapist or the views that scientifically you should have. For example, if someone is having sleeping difficulties due to his psychotic experience, hallucination, delusional beliefs, psychotic anxiety, and he's having his antipsychotic medication, he might think that he's actually taking sleeping pills, which do help him to sleep better, while we do think that he's taking his antipsychotic medication because he's psychotic and he doesn't want to have these psychotic experiences. So health belief model works for him and for us also because he thinks that he's vulnerable, unable to sleep properly, and medication does do strengthen him. So he is taking that. But his view is different from ours. So we should be quite flexible and respectful to his view if we want to achieve better treatment adherence. Depression is another topic which is quite often mentioned in studies regarding insight, how insight affects depression. And actually, Dr. Avram pointed out through the mechanism of denial and this, how he mentioned the sealing over effect, that poor insight in the beginning of the disease, on the other hand, higher level of insight in the beginning of disease can lead to more severe depressive symptomatology. This has to do actually, and it's often observed in more cognitive flexible patients, and it has to do with very nucleus component associated with insight. And they have better awareness of having a mental disease, a serious mental disease. They are aware of the pathological nature of their symptoms, and they can have a view or fears about the potential outcomes. So higher insight in at least the early stages of the disease can lead to more serious depressive symptoms. We should be also careful though, because that doesn't mean that whoever have depression in the beginning of a schizophrenic or in the course of a schizophrenia, this is only due to the fact that he's having higher insight. This can be attributed to other factors, like having some delusional beliefs, having some hallucination, some experiences of hallucinations that can make him depressed, or having a schizoaffective disorder, or simply has to deal with the consequences in his social life and the adverse events that the schizophrenia causes to his life in general. Nevertheless, we should be aware that acquiring insight in the course of the disease can lead to more depressive symptoms, although studies, and we will refer to that later, can be contradictory. That doesn't mean that we shouldn't, in clinical view, be careful about the possibility of some having more depressive reaction when he gets more insight through the course of his disease. Speaking of this, insight, at least in some studies, can be related to higher risk of suicidal behavior, at least in the beginning of the disease. although increased insight in follow-up can reduce the risk. As expected, if insight remains stable, then the risk of suicide can be is stable due to it at least. So if insight is gained through the disease, so in the later stages after the first episode is reduced, then suicide risk is reduced also. On the other fact, if insight is lost through the course of the disease, suicide risk is getting more and more severe. The bottom line is that if someone is schizophrenic, among the things that can make him potentially suicidal is poor insight or the variances of insight. So in order to assess suicidal risk in the course of schizophrenia, we should monitor insight among the other symptoms that can cause suicidal behavior. At least in this study, which is old, relatively old, 10 years ago, but it's focused in patients which are violent and in correction facilities, schizophrenic patients. It's shown that 73 of the total variance of insight of violence can be attributed to some degree of insight impairment, any aspect of insight, lack of adherence to psychotic medication, and substance use. The thing is that this showed that lack of insight is an independent factor in this equation. So lack of insight itself, and not lack of insight that leads to poor treatment adherence, can be among the factors that can lead to other directed violence in schizophrenic patients. What about treatment approaches? Well, it's expected, it's logical to expect or to think what is happening if insight is a symptom. Then what does happen when someone is on medication? Does insight improve? Well, there are relatively weak data. First of all, treatment adherence doesn't seem to improve with compulsory administrations of the medication or compulsory admission to the hospital. That I believe it's a common knowledge that, if anything, treatment adherence and insight does not really improve after someone been compulsory admitted to the hospital. There are some data regarding the fact that second-generation antipsychotics are better in improving insight against first-generation antipsychotics, but overall are considered weak. The other thing is that although side effects of second-generation antipsychotics are less, so the adherence might be better, that doesn't really mean that insight is getting better also. On the other hand, there are enough data regarding psychoeducational approaches where psychoeducation does seem to have some effect and be effective in increasing insight, but although studies have their problems, but psychoeducation is something that is often viewed in the literature as an effective approach. Cognitive behavioral approaches, metacognitive treatment, or trying to reduce stigma has some results, but we should be careful about the patients that are more suitable. We tend to think that someone that is more cognitively flexible or less cognitively impaired from the disease is more, it's more likely for him to be to have more insight. This is not the case. It hasn't been proved. So, although these approaches can work, we shouldn't expect that since someone is cooperating, he will necessarily gain proper insight. On the other hand, motivational approaches like a good therapeutic relationship or and the most promising approach that was at least I read in the literature is to investigate attitudes towards treatment of the attitude of the patient towards treatment. This made it makes a good approach in order to increase insight. Social support also can play an important role, and to increase social support or to support their social their peers or whoever is supporting the patient, and some psychoeducational facts like the fact that more insight can lead to less possibility of being hospitalized again. Nevertheless, we should be careful about the fact that gaining insight, Dr. Avram pointed that out, gaining insight can trigger depressive reactions. So since we do not have very robust data about how we can achieve the one without provoking the other, we shouldn't say that we shouldn't try to increase insight, but we should be careful when insight increases for the possibility of a depressive reaction and deal with it. About the course of insight, there is a very good graphic representation in this paper mentioned below. But in general terms, insight tend, lack of insight impairment, tend to have the course of the positive symptoms when we have relapses. It tends to be more impaired. When we have remissions, it tends to be less impaired, and that ends up in a V-shaped curve of insight, of insight impairment, where some insight is gained in the midlife, some better insight is gained in the midlife, but this curve, this trend does not continue in late life, where although we do not have severe relapses and patient is going to a residual phase of his disease, insight is getting more and more impaired from late life after 60s until the end of life in schizophrenic patients. Concluding, as conclusions of my talk, I have to point out, like, the common knowledge that the lack of insight is amongst schizophrenia symptoms. It's a symptom of the disease. Lack of insight is generally correlated with poorer treatment and outcomes and worse prognosis. And lack of insight is also correlates with the risk for violent and self-destructive behavior. Psychoeducation and other psychosocial approaches can have better evidence regarding its improvement, but due to methodological difficulties, studies encounter great difficulties regarding insight assessment and interventions regarding its improvement. Thank you very much.
Thank you very much, all. We are looking forward to hearing your questions and comments. Yes, please.
University of Thessaloniki and Hellenic Observatory of Corporate Governance. I think that would be better to take questions at the end. So first will be Ms. Stefania Moisidou and then Ms. Irini Tsitsipa. Ms. Stefania, please. Moisidou, sorry.
Good morning all, and thank you very much, Professor Athanasiadis. And I would like to thank Professor Foundoulakis for giving me the chance to be part of this great congress among so many well-known and great scientists. We will see the evidence regarding cognitive behavioral therapy, psychoeducation, interpersonal and social rhythm therapy, family intervention, intensive psychosocial intervention, cognitive remediation and functional remediation, mindfulness-based interventions, internet-based interventions regarding, of course, bipolar disorder. It is well known that bipolar disorder has an unfavorable outcome. It is a chronic and severe illness that affects a considerable number of patients. Patients have chronic mood symptoms, and gradually they have a significant global disability and burden. And of course, burden is not only for patients, but for their families and for society. We can divide the overall functional outcome in two dimensions. The first is clinical severity, while the second one is cognitive dysfunction. Symptomatic remission, on the other hand, does not imply functional recovery. And this is quite important because functionality is a very serious and important factor for the patients feeling well. It has been shown that subsyndromal symptoms, together with psychosocial stress at baseline, are factors, negative factors, predicting earlier relapse. And as well as other studies show that poor adherence is also a predictive factor of poorer long-term outcome. On the other hand, a positive factor is early successful treatment with full recovery for a better long-term outcome. Pharmacological treatment, of course, is the first choice of treatment. However, it fails to address all the patient needs. And there is a gap. So in order to fill this gap, the need for development and implementation of other intervention was very important. And so psychotherapies come to fill this gap and eventually improve the illness outcome. However, it's not quite clear which psychotherapies truly work and in which patients they are more eligible, while the time of intervention is also an open question. Most studies are focused on acute depression and the maintenance phase, while mania is not so well studied. Of course, there are many limitations, and this regards to most psychotherapy, in general to psychotherapy. And there is no universally accepted standard method to conduct those kind of therapies. And of course, those limitations, it is difficulty to resolve them. Starting with CBT, it includes education about bipolar disorder as a diathesis stress illness. It enhances cognitive behavioral skills. It focuses on routine and sleep, treatment adherence, triggering factors, vulnerabilities, dysfunctional thoughts, and underlying maladaptive assumptions. Clinical data, where there are studies that show the superiority of CBT when controlled with treatment as usual. However, the results are not sustained. As you can see, they were not there after 18 months. And while other studies have showed equal results comparing CBT with treatment as usual. However, when CBT is combined with psychoeducation, then the results seem to be sustained after even 5 years. And there are studies that support the superiority of CBT plus psychoeducation to psychoeducation alone. In general, we could say that there is an overall positive support, but it is limited to the usefulness of CBT during the acute phase. However, there are no results, positive results, for the maintenance. This is probably because this could be better results could be found when CBT was for patients in earlier stages of the illness. Regarding psychoeducation, it includes training of patients regarding the overall awareness of the disorder, treatment adherence, substance abuse, the avoidance of substance abuse, early detection of signs and episodes. It focuses on regular habits and stress management. And psychoeducation has limited number of sessions, only 7 to 12. Studies are more conclusive regarding psychoeducation. In most cases, it is superior when compared to treatment as usual, and the results are sustained after follow-up. There are positive results regarding symptoms of mood symptoms, and particularly manic symptoms, but not depressive ones. And there are positive results for recurrence, hospitalizations, and overall clinical improvement. In a post-hoc analysis, post-hoc analysis showed that patients with more than 7 episodes did not improved significantly in time to recurrence, and patients with more than 15 episodes did not benefit in terms of time spent ill. There are some interventions consisting of training community mental health teams where only occupational functioning resulted as a positive outcome. In general, we could say that psychoeducation does not improve depressive episodes and symptoms, and however, it is less costly when compared to CBT. So we could say that it has a long-lasting prophylactic effect, which is probably restricted to manic episodes and to patients at the earlier stages of the disease who have achieved remission. And although the mechanism of action remains unknown, it is highly likely that the beneficial effect is mediated by the enhancement of treatment adherence, lifestyle regularity, healthy habits, and teaching of early detection and prodromal signs. Interpersonal social rhythm therapy. It includes management of affective symptoms through improvement of adherence to medication and stabilizing social rhythms, and resolution of interpersonal problems. Studies are not very conclusive. There is one study that had equal results when controlled with intensive clinical management regarding to remission. However, IPCRT was more effective in in terms of survival. The patients survive longer without an episode, and so to higher regularity of social rhythms. In another study, there were equal results when compared to quetiapine, where both of them showed significant reduction in symptoms. Overall, there are no convincing data. However, there are some data suggesting that if applied early, might prolong the time to relapse. Family intervention. It includes psychoeducation, communication enhancement, and problem-solving skills, support and self-care training for caregivers. Family intervention targets, of course, the whole family and not only patients. Studies. There are not quite many studies. However, those made were focused mostly on hospitalization, where there are positive results that they reduce the odds ratio for hospitalization. And when combined with psychoeducation, communication skills, and problem solving, it seems that it is superior compared with treatment as usual in terms of hospitalization risk, relapses, and depressive symptoms. In another study, compared to treatment as usual, again showed positive results in terms of relapses and manic symptoms, as well as medication adherence. While in another study, family burden was the positive result. It can be said, in general, that those interventions could be beneficial for patients from families with high levels of impairment and could result in a reduction of both the number of depressive episodes and the time spent in depression. And in those patients who recovered from the intake episode, multi-family group therapy could be associated with the lowest hospitalization risk. So in general, the literature supports the beneficial impact, especially for family members, not for patients. Intensive psychosocial intervention. Intensive psychotherapy is another option. However, it is not well known its general efficiency. Few clinical data. Some results, they show some efficacy when compared to 3 sessions of psychoeducation in terms of recovery and greater likelihood of being clinically well. However, there were many methodological issues on this study. Cognitive remediation and functional remediation. It includes education on neurocognitive deficits, communication, autonomy, and stress management. Studies, when combined with neurocognitive techniques and psychoeducation and problem solving, showed better results compared with treatment as usual. However, this result was only for functional impairment, and there was no superiority when compared to psychoeducation alone. While in another study, when combined with social cognition and interaction training, it was again plus treatment as usual. It was more effective than treatment as usual alone. However, no differences were found between groups concerning social functioning. The results were all for emotional perception, theory of mind, and hostile attribution bias and depressive symptoms. Mindfulness-based interventions, they include education about the illness and relapse prevention, combination of cognitive therapy, training on awareness of the patterns of thoughts, feelings, and bodily sensations, development of a different way, non-judgmental way of relating to thoughts, feelings, and sensations, and promotes the ability of the patients to choose the most skillful response to those thoughts, feelings, and situations. Studies on mindfulness-based therapies were again superior compared to waiting list, however, only to symptoms of anxiety and depressive symptoms. What we need to keep in mind regarding mindfulness is that it mostly focuses on anxiety symptoms and not very well on mood symptoms. And there are no differences regarding relapse. So the overall data do not support the beneficial effect of mindfulness and the core issues of bipolar disorder. However, they suggest that it could be useful in the reduction of other symptoms such as anxiety. And so far, there are no data supporting its efficiency in the prevention of recurrences. Lastly, internet-based intervention. Actually, there was only one such trial that compared internet-based preventing program for bipolar disorder. The results suggested that there are no differences between both those treatment groups. And the design of the study precludes deriving general conclusions, while another study was conducted using mobile phone technology, and again did not show any benefits. However, this could mean that a mobile phone approach could be an important alternative. To gather what was said together, reviewing the data are rather disappointing. It seems that only psychoeducation is efficacious for the relapse prevention of mood episodes. However, this happens to a particular subgroup of patients that they were at early stage of the disease and had a very good remission. CBT and IPCRT could have some beneficial effect during only acute phase and not maintenance. Mindfulness interventions could only decrease anxiety, while interventions to improve neurocognition seem to be rather ineffective. Family intervention are beneficial, but mostly to patients' families and not patients themselves. And it is uncertain whether they have an effect in patient outcomes. In this table, we can see gathered all together the interventions and their efficacy. As you can see, CBT is effective in terms of depressive symptoms, while psychoeducation both for relapse and overall functioning, and mindfulness for the treatment of anxiety. Now, the mechanism responsible for the efficacy of psychosocial treatments are unknown. It could be suggested that the effect is mediated through the enhancement of treatment adherence, improving lifestyle and especially biological rhythms, food intake, attitudes, family interactions, and enhanced ability for the early identification of signs of relapse. It is possible that higher number of previous episodes, as well as psychiatric morbidity, so severity, morbidity, and functional impairment might reduce treatment response, although data are not conclusive. It has been also suggested that in the early phases, the intervention should be simpler, with a focus on neuroprotective strategies, while at later phases, the emphasis should be on rehabilitative intervention dealing with the specific disabilities of the patients. IPCRT and CBT might be also efficacious during the acute episodes, and specific characteristics of the family and environment have also shown influence in the response to treatment. It should be also mentioned that most of research concern pure and classic BDI1 patients, although there are some rare data concerning special populations like BD2, schizoaffective disorder patients with high suicide risk, and patients with comorbid substance abuse. Thank you very much.
Thank you, Ms. Moisidou, for your very complete overview. And our next speaker is Ms. Irini Tsitsipa, and her topic is very interesting, is the neurocognitive function in bipolar disorder. Ms. Tsitsipa is a psychologist, is currently working for the Newham Centre for Mental Health in East London, and she's also a member of the East London NHS Foundation Trust Research Unit. Ms. Tsitsipa, please.
Thank you, Professor Athanasiadis. Good morning to everyone. I'll be talking about neurocognitive functioning in bipolar disorder, but before I'll get started, I would like to thank Professor Fountoulakis for the invitation. I'll get started with some introductory information, and I'll go through every single cognitive domain. Afterwards, I'll be talking about clinical correlations, the trajectory of the deficit, patient's awareness, gender, the effect of gender, the deficit as in the phenotype, and last but not least, about the treatment. So, the neurocognitive dysfunction in bipolar disorder has been the focus for debate for many years. It wasn't really clear whether it could be explained by any iatrogenic factor, or by drug or substance misuse effect, or by temporary functional changes coming from mood changes, or by any other degenerative factor. We do know at the moment that the impairment represents a core primary characteristic of the illness, seems to be present even before the first manifestation of mood symptoms, worsens during the course of bipolar disorder, and is less pronounced in comparison to that seen in schizophrenia. The impairment is observed in the 57.7% of psychotic BD patients, and generally 40% of patients are impaired in one neurocognitive domain, 1/3 or more in at least 2 domains, and 22% in 3 or more domains. Concerning IQ, there is a moderate global reduction in IQ as it's reflected by patients' performance in neuropsychological batteries, irrespective of illness phase. The deficit is milder but qualitatively similar to those of patients with schizophrenia, and it's more pronounced when psychotic features are present. The effect sizes, according to meta-analytic studies for the full IQ, is 0.47, for the performance one, 0.06, and for the verbal one, 0.28. Unfortunately, there are no data for patients on depressive phase. A discrepancy between verbal IQ and performance IQ has been observed during euthymia. And this is not because of the slowing in mental speed, which is generally observed in patients with bipolar disorder, but it is due to the uniform reduction in all performance subtest scores with preservation of verbal IQ scores. The marked severity of depression, though, reduces that discrepancy, which we have to say that it's not observed in unipolar depressive patients. When all phases of the illness are taken into consideration, the effect size can go up to 0.70, and we've got inconclusive results for patients in remission. Psychomotor activation and mental speed are two concepts which overlap and include reaction time, cognitive and motor speed, manual dexterity, and they are clearly not identical. We have to say that most of the neuropsychological tools which are used to evaluate mental speed and psychomotor activation inevitably evaluates other cognitive domains as well. Because in order to measure speed, you've got to initiate a procedure whose speed is going to be measured. So, reaction time prolongation has been found in bipolar depressive and euthymic patients. It's associated with past history of depression, but not with current medication status. The mental processing speed is slower in patients with bipolar, irrespective of illness phase and symptom severity, and is less affected in comparison to schizophrenia. When all phases of the illness are taken into consideration, the effect size fluctuates between 0.50 and 0.55. During euthymia, it can go up to 0.80. Attention is a concept that includes a number of processes which work together, influence one another, and sometimes even prerequisite one another. For example, working memory is the ability to maintain awareness, limited number of mental objects for a limited duration of time. Vigilance is the ability to identify a specific target among other stimuli. Also the ability to rapidly shift your attention. So it's been reported a widespread deficit in attention in people with bipolar. The impairment is present already during the early stages of the disorder, is independent of the phase of the illness and of current symptomatology, and is less pronounced in comparison to that seen in patients with schizophrenia. We can see the effect sizes. For the overall one is 0.64, and during acute manic and mixed state, it can go up to 0.90. Learning is the ability to acquire and store new information, while memory is the ability to, which helps people to retrieve that kind of information at a later time. Both learning and memory includes more fundamental processes, for example, concentration, attention, allocation of effort, and encoding. The deficit has been observed in both memory and learning, and you can see there in the subtypes of memory. It's been suggested that the deficit in the prospective memory persists during remission as well. So many authors have argued that this might be a trait deficit. The deficit in learning and memory is less pronounced in comparison to that seen in schizophrenia. On the other hand, however, there are some negative studies concerning the presence of the deficit. We can see in that table the effect sizes, and we can see that the deficit concerns all phases of bipolar. The highest effect sizes has been observed in verbal memory and learning, and during acute mania and euthymia as well. So, concerning verbal skills, the evaluation of them includes mostly the evaluation of verbal fluency. Verbal skills are reported to be impaired during all phases of the illness. Some papers, though, suggesting that the impairment is not present during euthymia or during the first mood episode. The errors in speech are reported during the acute manic state, and they are independent from the coexistence of an attentional deficit. The effect size is smaller in comparison to that seen in schizophrenia and higher in psychotic bipolar disorder. We can see again in that table the effect sizes, and again we can see that the deficit has been observed during all phases. The highest are during depressed state and during euthymia. Visuospatial skills can be evaluated by complex ray figure, usually. There is an impairment in visuospatial and constructional abilities, in visual learning and memory, and in positional memory with a quite high effect size, can go up to 0.18. The impairment is reported to be similar in euthymic patients with bipolar and patients with schizophrenia. Some authors have suggested that there is intact visual motion integration. Also, some authors have suggested that the impairment is restricted in the acute phase, while these skills might not be affected during remission. The overall effect size is reported to be equal to 0.65, and in remitted patients it can go up to 0.57. So, the key phrase to describe executive functions is controlling of mental and neurocognitive processes. And this is because the executive system is heavily involved in planning, decision-making, error correction situations where are not well rehearsed or contain novel consequences of actions, are dangerous, or required to overcome a strong habitual response. A significant impairment in executive functions has been observed, except reasoning, and the deficit is present during all phases. It's early during the course of the illness, independent from the phase, and again less pronounced in that seen in patients with schizophrenia. Not all data, although, are straightforward. The effect sizes according to meta-analytic studies, you can see them in the table. It's impressive that the highest are during euthymia. Social cognition is a multidimensional concept. It includes theory of mind, which is the ability to attribute mental states to oneself and to others. emotion processes, which is the ability to identify and discriminate basic emotions, and emotional decision-making, which is crucial for appropriate social interaction, and it's about weighting up choices in regards to punishment and reward. So there is deficit in theory of mind. It's independent of other cognitive dysfunction, and it's doubtful whether it's related to a history of psychotic symptoms. Probably the impairment in DOM is associated, it might reflect more fundamental underlying neurocognitive deficits rather than representing a trait marker of the disorder. We've got inconclusive data concerning emotion processing. We do know that patients don't really manifest impairment in face recognition in general, but they were impaired in the facial affect labeling. It's been found that probably specific faces affect specific emotions, and patients on acute mania are impaired in the recognition of fear and disgust, while during euthymia they can recognize disgust in a better way. There is little or no difference between patients with bipolars and controls on the emotional decision-making component. The impairment might be predicted by low level of education, family history of bipolar, benzos, and antidepressants. In that table, we can see, we can see the tests which are used to evaluate every cognitive domain. We can see that the tests which are used to evaluate social cognition and theory of mind includes both scenarios, verbal and non-verbal tests, and they demand from the subject to comprehend a social situation and to plan ahead. So, medication constitutes an important confounding variable. Some acutely ill patients might be medication-free during testing, which is not the case with patients in remission. So, medication could be a significant confounding variable, which is very difficult to control for, and at the same time, it can introduce a bias towards the detection of the deficit. So, we don't really know whether the observed deficit is medication-induced or it's caused by the illness itself, but we should differentiate it because the determination of that differentiation will have beneficial effects not only in the long-term therapeutical design, but in the overall outcome of the illness as well. So we do know that lithium negatively impacts verbal memory and learning, psychomotor speed, and fluency, but there are no adverse effects in attention and encoding. Patients under lithium often report that it inhibits their productivity and creativity. But again, we don't really know whether it's a true deficit or it's a reflection of it's their personal cognitive subjective complaint coming from the transition from manic states to euthymia. The deficit from lithium is reversible when lithium is withdrawn and reestablishes when the agent is readministered. Anti-epileptics causes a deficit in attention, psychomotor speed, word finding, and verbal memory. And we can see in the table that antipsychotics causes a deficit in the domains there. Again, we don't really know whether the observed deficit is antipsychotic induced or it's the consequence of the manifestation of psychotic symptoms for the treatment of which antipsychotics were prescribed. So it's unclear whether it's the poor treatment adherence which leads to worse neurocognitive performance or is the worse neurocognitive performance which leads to poor treatment adherence. It's evident that medication probably caused some degree of neurocognitive impairment in psychomotor speed and sustained attention, but overall, the literature suggests that medication have a limited adverse effect on cognition, if any at all. So it's been found concerning the psychotic symptoms that the presence of psychotic symptoms is strongly related to a worse overall neurocognitive performance. In the absence, even in the absence of current psychotic symptoms, a history of psychotic symptoms is related to worse neurocognitive functioning. Patients with bipolar generally perform better than patients with schizophrenia. There is a possibility that cognitive differences between psychotic and non-psychotic patients are in fact the result of an earlier onset of the illness or medication use rather than a result of psychosis per se. It's been found that acute mania and depression causes an impairment. We do know that fluctuations in both manic and depressive symptoms have an appreciable impact on functioning. A number of research studies and meta-analyses have suggested that significant impairment is present during remission and in all domains, and there is one meta-analysis showed that the illness phase had no effect on the short-term memory deficits. There is a meta-analysis which confirmed that neurocognitive impairment is present during all phases of bipolar disorder. This result suggests that the patients in manic or depressed state had significantly greater effect size impairment in verbal learning than patients in a euthymic state. And despite the observed strong relationship between mood symptoms and neurocognitive impairment, the overall evidence suggests that the deficit is not secondary and doesn't constitute a byproduct of mood symptomatology or of exposure to medication. The most probable explanation is that the neurocognitive impairment reflects a deeper neurobiological dysfunction, which probably includes the presence of premorbid developmental abnormalities. The severity of the impairment is related with the age at onset, the duration of illness, previous episode and prior hospitalizations, a history of mood disorders, and suicide attempts. The role of other clinical factors now. It's been found brain white matter lesions has been found in repeated patients with bipolar disorder, but they do not underline a neurocognitive deficit per se. Likewise, comorbid alcohol use disorder. It's been found that obese patients and overweight ones have worse performance in tests of verbal fluency. Education could probably constitute another significant confounding variable. It's been found that patients with bipolar have lower level of education, and generally it's been suggested that shorter duration of education is associated with lower performance in neuropsychological batteries. So there is a possibility that education is a marker related to the onset and the severity of illness, because the early onset of illness and the severity interferes with educational attainment, and the other possibility is that education constitutes a protective factor per se. So I'll go straight away in the graphical representation here. As we can see, the deficit, people with bipolar disorder have intact neurocognitive performance during childhood and adolescence. We can see that their performance gets worse after the manifestation of the first episode. It has upward and downward trends, and as time goes by, we can see that they have the tendency to have the same performance as people with schizophrenia have. There are limited data on the relationship between subjective cognitive complaints with objective neuropsychological deficits. The patient's self-reports of impairment do not correlate or predict objective neuropsychological deficits. Maybe there is some weak correlation between subjective complaints and deficits in certain domains. We've got conflicting results for the presence of a gender effect. Male patients manifest a more severe deficit in immediate memory and executive function, and female ones shows better memory performance, and there is no gender effect on emotion recognition. Endophenotype is associated with a specific disorder in the population and should be heritable and state-independent. Endophenotype is found in non-affected family members at a higher rate than in general population. Twin studies have come up with the conclusion that unaffected co-twins suffered from minor or subthreshold mental disorders and dysthymia. Monozygotic and dizygotic twins shows impairment in a number of cognitive domains as well. Studies on first-degree relatives have come up with the conclusion that specific executive functions might be impaired in high-risk children in comparison to controls. So, executive function, response inhibition, verbal memory, and attention, sustained attention, could serve as an endophenotype for the illness. It's almost certain that IQ cannot serve as one. Concerning the treatment, it's been found that galadamine may have specific benefits for episodic memory, but not processing speed in patients with cognitive impairment as part of bipolar. Pramipexole may improve neurocognition in euthymic patients. Adjunctive intranasal insulin might have beneficial effects on executive function, but not on the other neurocognitive measures in euthymic patients. Adjunctive mifepristone improves spatial working memory in depressed, in patients with bipolar in depressed state, and this was evident also 7 weeks after the cessation of treatment. NSAID produced an improvement in neurocognitive function similar to that of algorithm-based pharmacological treatments. So, in a nutshell, the deficit is a core deficit, seems to be independent of mood symptoms, concerns all domains. The severity of it related with the disease phase, the clinical course of the illness, patient's age, gender, and education level, the presence of psychotic features. Medication have a limited adverse effect on cognitive function. Thank you for your attention.
Thank you, Ms. Tsitsipa, for your very interesting presentation on a very challenging topic. And I think we have time for a couple of questions, if there are any. Any questions? I've got a question for you, Ms. Tsitsipa. Are there any deficits in bipolar II? Can you have the micro, please?
Thank you, Professor Athanasiadis, for such an interesting question. The truth of the matter is that there are so many studies indicating that people with bipolar II perform in a better way than people with bipolar I, or in a better way than controls, or people with bipolar I. Generally, the literature suggests that yes, there is an impairment in bipolar II, and the effect size of that impairment fluctuates between, if I'm not mistaken, 0.60 to 1 point something, 1.15, 20, and the deficit has been observed in many domains like attention, working memory, and executive functions. On the other hand, however, of course, there are studies indicating that there are intact domains. The prevailing opinion is that bipolar II patients perform better than controls, but worse than, they perform better than bipolar I patients, but worse than controls. So they are positioned in between these two categories. But the literature suggests that bipolar II doesn't really differ much from bipolar I.
Okay, thank you. And I've got a last question for Ms. Moisidou. If I'm not mistaken, you haven't mentioned psychoanalysis. Do you have any comments?
Yes. I was expecting such a question. Actually, there are no evidence-based studies regarding psychoanalysis or other analytical treatments. And this gap probably cannot be filled. And that's why there was no presentation.
Okay, very clear. Any other questions? Okay, thank you so much. And I think we can proceed with the next symposium. We'll have a chance. I'll be chairing this symposium with a very challenging topic, hidden aspects of schizophrenia. And we've got two speakers, if I'm not mistaken. Two speakers and two other speakers are not able to attend. So we'll start with Dr. Elias Andreoulakis. Dr. Andreoulakis is a psychiatrist. He completed his studies at the HEPA Psychiatric Hospital in the Department of Psychiatry. He completed his PhD in 2012, and he's very actively involved in psychoanalysis and psychodynamics, and his topic, of course, will be a similar one, is psychodynamic issues and schizophrenia. Dr. Andreoulakis, please.
Good morning. Thank you, Mr. President. Dear Professor Foundoulakis, I would like to thank you for the invitation. We're talking about hidden aspects of schizophrenia, including psychodynamic issues that would be clinically relevant. A prominent feature of psychosis and schizophrenia is a denial of unbearable aspects of reality, both external and internal, the latter emphasized particularly by psychoanalysis. The subject creates an altered relation with reality and creates a new reality which is more acceptable or rewarding. It can alleviate and transfer internal conflict from the inside to the outside, where there are more chances of escaping or even attacking. This can be seen as a compromise formation and a defense against total breakdown or disintegration, as a self-preservative, though painful solution. Concerning vulnerability, biological vulnerability is undoubtable. On the other hand, traumas, adverse early experiences, deficiencies in early object relations also play a major role. A symbiotic relationship promoted by the primary object, meaning the mother, versus a separation and individualization enhancement, an intrusivement or inconsistency in care on part of the primary object, and an inability to contain emotions, feelings, fantasies of the infant and metabolize them in a more acceptable way, all lead to severe deficits. And deficiencies in the differentiation between me and not me, between in and out. There are severe deficiencies in basic trust and a hampered progress to depressive position as postulated by Melanie Klein. There's a severe deficiency in the symbol formation procedure and the capacity for abstract thinking. The integration of the self and the object also suffers, and there cannot be an adequate dominance of good over bad experiences, of love over hate, and life over death instinct. As Bion has emphasized, schizophrenic patients struggle with a never-residing fight between the life and the death instinct. Psychodynamic issues to be addressed that would be clinically meaningful for practice in general psychiatry are related to defense mechanisms, transference, countertransference, and personal meaning the patient attributes to his state or to previous experiences, and addressing questions regarding many whys. Biological vulnerability is not to be disregarded, but there's also a space to address some questions such as why now? What made development of a psychotic episode possible? Why this type of content or this type of symptoms? Concerning defense mechanisms, patients with schizophrenia are in a severe regression, meaning that they roll back to earlier stages of psychosexual development, mainly oral as postulated by Freud, or schizoid paranoid position as postulated by Klein. Another dominating defense mechanism is splitting. Splitting refers both to the ego and the object. It means that the ego is dichotomized and unbearable parts of it are expelled through the mechanism of projection or projective identification. What Rosenfeld has emphasized and contributed to the understanding of splitting is that splitting might be preceded by a fusion between self and the object, by a fusion of aggressive and sexual impulses. So splitting cannot be seen as the bottom line of the manifestation of a psychotic episode, but it might as well represent some line of progress depending on the starting point. Projection is another mechanism by which unbearable parts of ego or emotions, fantasies are expelled and transferred to the object. Projective identification is a more sophisticated defense mechanism, which we'll see in detail in the next slide. Denial is also present and refers to both external aspects of reality and internal, and omnipotent control often takes also place. What is noteworthy is that there can be some control mechanisms, as I could call them, or compulsive behaviors that might be in play in patients with schizophrenia or vulnerability for psychosis. They are important to address, And I would like to mention a case report. I was glad to work with Professor Athanasiadis with it. There was a male patient that was treated for paraphilia with CBT, and after successful management of his treatment, he manifested a psychotic episode that warrants further investigation of underlying dynamics before deciding to address or remove any kind of compulsory symptoms or even perversions. Let me speak about projective identification. This is a sophisticated defense mechanism, a primitive defense mechanism, which is a characteristic of the way schizophrenic patients try to deal with the internal conflict. It's a three-stage phenomenon, including projection, as we said earlier, of unexpected parts, identification with the object to which those particles of the self are expelled, and reintrojection of this material back to the self in a way that depends on the metabolizing capacity of the recipient, of the object. Thus, this material could be amplified, these anxieties could be amplified or attenuating. The purpose of projective identification is the evacuation of unbearable content and avoidance of internal conflicts. The subject tries to preserve the internal good object. Another purpose is to enter, take possession and control of the object, leading it to feel or act in a way that the subject would aim to. What Rosenfeld has pointed out is that projective identification can also serve as a means of communication. It's a desperate way to make you feel that or to make you act in a certain way. We can see that due to projective identification, there might be a replication of early experiences with paternal or maternal figures during transference. This kind of communication is similar to this established in pre-verbal stages of development where need could not be put into words easily. Transference is another field of interest in psychoanalysis. Transference could be idealizing and reaching even delusional transfers with either positive or negative characteristics. There might be rivalry and aggression on behalf of the patient and sexual or aggressive fantasies. What is important to mention is that there could be envious attacks on the analyst, often after an initially received interpretation. Tendencies for disengagement due to the fear of dependency or engulfment or even annihilation. What is important in schizophrenic thought is the incapacity for symbolization and abstract thinking. There is no space for metaphors, there is no space for quotation marks, and things are taken literally. Words are taken as things in themselves, and they are often expelled or thrown at the analyst with the purpose to injure physically or mentally by attacking his capacity to think. Symbolic equation from such as mother equated to the breast, the partial object, might also be present in the equation between doctor and the pill and the medication. Content transference has been regarded initially as a drawback, as a matter of personal interference that warranted further analysis or supervision on behalf of the analyst. But now it's seen as a valuable means for understanding the patient dynamics, the patient feelings, fantasies, and thoughts. From this aspect, from this point of view, we can have another look and shed further light to feelings of frustration, helplessness, fear, or anger that might be aroused in the analyst or in the therapist. As we said earlier, psychoanalysis could contribute to addressing some meaningful whys, such as why now? This could be clinically meaningful by addressing and identifying triggers for a psychotic episode or a psychotic relapse. Triggers could not always be easily identifiable in external reality. They could be latent, not to mention that they might be placed in internal reality. So we have to identify sexual or aggressive impulses, primary anxieties that might have given rise to psychotic symptoms, and to try to link events between them that were previously disconnected. As Björn has pointed out, the schizophrenic patient exhibits severe attacks on linking. Linking refers both to the capacity to link emotions and fantasies, thoughts between each other, which is manifested in the derailment of association often seen in schizophrenia, but also to the linking and the bonding with another object, with another person, with the object. The schizophrenic patient seems to be attacking his own mind. Answers about whys might also refer to the type of symptoms the patient develops and the certain type of content, because there might be a personal meaning behind them. It's an attempt to make reality bearable and avoid frustration, inferiority feelings. What's often seen is a denial of homosexual fantasies associated with paranoid ideas, or the projection of aggressive or sexual fantasies, including exhibitionism and voyeurism. A patient in delusional state, believing that he is spied upon, might have projected his own curiosity to watch, or his underlying grandiosity ideas that he is worth watching or even spying. In that way, psychodynamic oriented approach can help to monitoring of the evolution of the symptoms, the evolution of the defenses employed, the severity and the intensity of these defenses, and perhaps the emergence of higher level defenses in the course of the disease or in the course of the episode. The evolution of language and thought process in the patient, his capacity for symbolization and acceptance of as-if conditions, a space, whether there will be a space for ambiguity, doubt, and ambivalence. His capacity to be alone after having internalized the object, his progress towards integration, which is manifested in his transition to the depressive position, where concern for the object, guilt, and urge for reparation emerge. And a better definement and establishment of in and out boundaries and responsibility, taking responsibility of one's own thoughts and feelings. What is also important to address is the personal meaning patient attributes to past experiences, to precipitating events before a psychotic episode which might be disconnected or irrelevant or thought to be irrelevant, to his current state and symptoms, the meaning that they carry, and his attitude towards treatment, including both medication and hospitalization. Psychodynamic therapy has failed to be established among first-line treatments or self-efficient treatments for schizophrenia. Psychopharmacology has undoubtedly represented a major breakthrough in the treatment of schizophrenia. However, it is recently recognized that psychodynamic approach could contribute to a better understanding. This is also included in NICE guidelines, that such an approach would help practitioners better understand the patient, his experience, the personal meaning he attributes to this experience, and his attitude towards treatment. It can also help unravel family dynamics and identify potential triggers. Triggers identification is very important since it might enhance relapse prevention. Psychodynamic understanding could also help in evaluating the progress and the evolution of symptoms or the response to treatment. Concerning treatment, psychodynamic psychotherapy could be addressed, could help and be involved in treatment either directly through a modified technique. Couch is not used. Silence is used judiciously, as well as interpretations. It could accompany the patient through a grief process after gaining insight in what might be seen as a post-psychotic depression. It could also help indirectly by enhancing the therapeutic alliance and the adherence of patient to the regimen and the treatment. It can also help identify feelings that arouse in the therapist that might be due to projective identification, and thus help understand what is happening within the patient, rather than attributing these feelings to oneself. Thank you very much.
Thank you, Dr. Andreolakis, for your very interesting psychodynamic overview of the topic. Are there any questions for Dr. Andreolakis? Yes, please. Sorry, can you repeat the names? Benedetti and the Greek one? Menzo Stavros. I'll translate. Our colleague is asking whether Dr. Andreolakis has any comments on Benedetti and Menzos, two doctors who have written on the psychodynamic treatment of schizophrenia.
Yes, there are, of course, some interventions in treating schizophrenia psychoanalytically in psychodynamic psychotherapy with slightly modified techniques, as you mentioned. There is also the Open Dialogue program in Finland by Seikula and other investigators. There are promising findings, but the results are limited so as to establish psychoanalysis as a first-line treatment. I think that it could contribute to a better understanding and the treatment of schizophrenia, but there is more to come in the future with RCTs and better design studies.
Okay, thank you, Dr. Andreolakis. Are there any other questions? If not, we can proceed with the last speaker, Ms. Nicoletta Petalidou. Ms. Petalidou has completed a number of degrees in the Netherlands and the UK. She has followed a Master of Science in Neuropsychology and Psychopharmacology at the University of Maastricht, and is currently working at the same institution as a research associate. Ms. Petalidou, please.
Dear all, good afternoon. Professor Athanasiadis, Professor Foudoulakis. Initially, I would like to express my gratitude for the invitation and the opportunity to participate in this significant event of great importance. So, the human theories of Galen, which dominated medical throughout many centuries, included bodybuild as an integral part. Various types of bodybuild were described, supposedly due to various humoral admixtures associated with specific temperamental traits and mental disorders as possibility. Ernst Kretschmer developed a theory based on constitutional approach, identifying 3 body types with different characteristics. These theories are abandoned today. Psychiatric manifestations are not considered to be correlated with the somatic constitution. More theories have raised the issue of development in relationship to the levels of androgens in utero. It is well known that these hormones affect postnatal laterality preferences, with high levels being associated with left-handedness of offspring. As we can see, an increased risk of schizophrenia is associated with exposure to famine in utero, prematurity, low birth weight, and poor maternal care during pregnancy. In adults, we have a number of observational studies suggest that obesity is associated with psychiatric disorders such as schizophrenia, depression, and bipolar disorder, although there is a strong relationship between the increase in body weight and treatment with antipsychotics. In this specific study, we had a sample of 1,116 subjects, of which 788 were normal control subjects, 76 patients with unipolar depression, 16 patients with psychoaffective disorder, 122 patients with schizophrenia, and 78 patients with other mental disorders. The clinical diagnosis was according to DSM criteria, and we had the somatometric measurement of the height and weight of all control subjects was measured with standardized weighting machines so as to have a reliable measurement and comparable across machines. Body mass index was calculated as the ratio of weight in kilograms to the square of heights in meters. To transform the statistical analysis, the first step was to transform the data to percentile scores, and the rank and percentile method was used. We used also the multiple analysis of covariance with diagnosis and gender as grouping variables, age as covariant of height, weight, and BMI as dependent variables. The Schaeffer was used in post-hoc test analysis. In the results, we see significant differences in terms of height between unipolar depressive males and normal females. Normal males and males with schizophrenia with unipolar depressive patients be shorter in comparison to other groups. In terms of weight, there were no significant differences among groups, and in terms of BMI, unipolar depression females had significantly higher BMI in comparison to normal females and males with schizophrenia. We see the table of the results here. And in the discussion, we had differences in terms of height between unipolar depressive males and normal females. The normal males and females with schizophrenia with unipolar depressive patients being shorter in comparison to other groups. In terms of weight, there were no significant differences among groups. In terms of body mass index, unipolar depressive females had significantly higher BMI in comparison to normal females and males with schizophrenia. Patients with schizophrenia do not differ from controls in terms of height, weight, and BMI. There is wide consensus that being overweight and obese is a significant problem for both patients with schizophrenia and mood disorder. Moreover, a plethora of clinical and epidemiological studies dating back to the beginning of the 20th century, that is before the psychopharmacological era, suggest that there is a link between height and schizophrenia. We have another study that had discussed the evidence that the body mass index distribution of the sample population is different from that national population as represented in the NPHS data. Higher BMI was associated with a highly comparatable pattern of gray matter reductions in the medial prefrontal cortex and orbitofrontal cortex, the caudate nucleus, and the thalamus in patients and healthy control alike. And the findings in this study allow to state that schizophrenic patients under continued use of antipsychotics are high at risk of obesity and deserve clinical, nutritional, psychiatric, and psychological attention, since obesity is a risk factor for several health problems that increase morbidity and mortality rates. I went through very quickly since I'm the very last speaker. Thank you.
Thank you, Ms. Petaloudou, for your very interesting overview of the somatometric characteristics in patients with schizophrenia, very concise and to the point. Are there any questions for Ms. Petaloudou? Or any comments? Okay, thank you so much.
Thank you.
And I think it's time now to ask Professor Foundoulakis to come to the podium for the closing remarks. Professor Foundoulakis, please.
Αν δεν κάνω λάθος, είμαστε μόνο Έλληνες τώρα αυτή τη στιγμή εδώ, οπότε μπορούμε να είμαστε λίγο πιο οικογενειακά. Σας ευχαριστώ όλους που ήρθατε, που ήσασταν μαζί μας και αυτή τη φορά. Όπως είπαμε, το επόμενο θα γίνει στην Καβάλα τέλη Ιουνίου, σε 1 χρόνο από τώρα, και θα αφορά την βασισμένη σε δεδομένα ψυχιατρική. Χθες έδειξα δεδομένα και στατιστικά του συνεδρίου. Νομίζω πήγαμε καλύτερα από κάθε άλλη φορά. Ευχαριστημένος. Λοιπόν, ξανά σας ευχαριστώ πολύ. Οι εργασίες έληξαν και πάμε σπίτια μας.